Okay, so hi guys. So I'm gonna jump right in. So we're gonna do shock, heart failure, and then any of the relevant pharm. So I started off with the baroreceptor reflex. This is like a true like physio concept. You absolutely have to have down pat. They will just bring up the baroreceptor reflex like randomly in like heart failure, the RAAS. You can't hear me? Oh no. Is it just can other people hear me? Oh, you can hear me. Oh no. Make sure you don't have your AirPods plugged in. Okay, sounds good. Yeah, sometimes if you have your AirPods plugged in, even if you don't have them on, they like, I don't know. Okay, good. Glad you guys can hear. Okay, cool. All right. Okay, so what was I saying? Okay, and then the renin-angiotensin-aldosterone system. This thing is huge. You'll see RAAS is like important for everything. Go into shock, heart failure, and then the relevant pharm, and then I'm ending with some questions. Okay, so first going into the baroreceptors and RAS, but starting off with what are baroreceptors. Before I talk about baroreceptors, I wanted to start off with some definitions because these are just going to be important for like just understanding pathology states, what certain drugs do, like things like that. So the first thing is stressed versus unstressed volumes. So an unstressed volume, this is the volume of blood in the veins. And just like a fun physio fact is that the veins are the biggest reservoir for blood because they have super, super high compliance. So sometimes they'll say like a drug like affects the unstressed volume rather than the stressed volume. They're talking about like the venous volume. So like something like a nitrate which has venodilation as well as vasodilation, like nitrate drugs affect both the unstressed and the stress volume. So if you see those terminologies, that's what they're talking about. Stress volumes, this is obviously the volume of blood in the arteries. And so this is like the blood going to the tissues. So I think about it as like it's super stressed, right? It has to go like give all this oxygen to the organs. But those are those definitions. And then similarly, like I kind of mentioned, vaso versus venoconstriction, again, completely talking about this in terms of like the RAS system, relevant pharm. When they talk about vaso, oh no, people can't see the slides. Oh my gosh, we're having so many issues today. Um, is it just you that can't see them? Okay, so other people can see them. I'm so sorry, everyone. Um, I'll try to, okay, sounds good. I'll try to like make it really obvious what slide I'm on. So you can follow along with at least the one without the questions, the ones that you guys have. Okay. So vasoconstriction, this is arterial constriction. So when they talk about vasoconstriction, they're straight up talking about something that's going to increase the total peripheral resistance or the SVR, TPR, same thing. This is going to increase resistance to flow. So when you think vasoconstriction, think increasing of afterload. Venoconstriction is venous constriction. This has absolutely nothing to do with TPR, SVR, absolutely nothing. And what I like to think of this as like the veins pushing blood into the right atria, which would increase preload. And I know you guys are sitting there probably like, okay, yeah, like those are definitions. But if you think about it, like if you vasoconstrict, you're basically stopping blood flowing, right? If you venoconstrict, you're actually like pushing blood ahead. They're like the exact opposite things. That's why it's really important to understand these definitions. So vasoconstriction, you're basically increasing resistance to flow. So that's why the blood should technically, go slower. Venoconstriction is like you are pushing blood ahead. It's like you're giving it a little push. Okay, so it's like you're decreasing that unstressed volume. You're trying to get it up there. You're trying to get it back to the heart. Okay, so that's why vasoconstriction, you're increasing afterload. Venoconstriction, you're increasing preload. Again, I'm only bringing up these definitions because some of the drugs will say like, oh, the veins are affected or the arteries are affected. And you kind of have to know because that's when they'll tie in these physio concepts like afterload, preload. Okay. All right, and then I wanted to talk about your G protein coupled receptors very briefly. I actually have, and I put this little reminder for myself. I actually have a G protein coupled receptor PowerPoint, and it goes through like the mechanism of actions of all the GPCRs, like how they work, what are the second messengers, things like that. If you didn't do G protein coupled receptors in pulm, do them. Like, you have to do them. Like, they come up every block. Even like your endo block is like, there's a ton of GPCR questions on that block. Same with this block, because, you know, like beta 1 receptors, alpha 1 receptors, these are all G protein coupled receptors. Okay, so, and on your study guide syllabus thing, it even said like, know these mechanisms. So definitely go through that. But at the very least, I put what type of receptor is relevant in the cardio block and like what type of G protein is it. So obviously the most important one is a beta 1 receptor. So beta 1 receptors, these are coupled to a GS protein. Sometimes you also see like G alpha S, they're the same thing, G alpha S, G alpha I, G alpha Q. So if it's GS coupled, that means its second messenger is going to be cyclic AMP, so it's going to increase cyclic AMP. Beta 1 receptors respond to epinephrine and norepinephrine, so these are typically like sympathetically controlled receptors. If you stimulate beta 1 receptors, you should get contraction. So if you think about, if you want the heart to beat faster, there's beta 1 receptors in the heart, you can release epinephrine, norepinephrine, you know, when you're exercising, and then you'll get more contraction. If you inhibit beta 1 receptors, that's when you get relaxation. So for example, you give a beta blocker, a beta antagonist, you're trying to get the heart to basically like chill out. Okay, so that's kind of like what those drove. And again, we're going to talk about beta blockers later, but that's like what they're specifically trying to block these GPCRs in the heart. Muscarinic 2 receptors, so M2s, these are GI coupled. So if it's a G alpha I GPCR, you're going to have a decrease in cyclic AMP. That's like how it works. It just basically stops what GS does, basically. These are parasympathetically controlled, so they're going to respond more so to acetylcholine. And if you stimulate the M2 receptors, you get relaxation. So note the difference here, like stimulation of beta 1, you got contraction, stimulation of M2, you get relaxation. It's just going to depend on what, like, you know, cell that receptor is in. So since this is parasympathetically controlled, parasympathetic system, this is your rest and digest. So it makes sense if we have parasympathetics acting on these receptors, we get relaxation. So similarly, if you were to give like a beta blocker to chill the heart out, same thing. If you activate these muscarinic 2s, these can also help relax. Okay, so kind of wanted to show like the parallel there. This is from, pretty sure this is from Klabunde's site. So just as an example, cells can have all different types of GPCRs on them. So for example, here's norepinephrine that's binding to beta 1 and beta 2s. We didn't really talk about beta 2s. They're more important for pulm, as you guys know. But norepinephrine really, that's why it's a really thick arrow. They really act on beta 1s. Parasympathetic nervous system, like acetylcholine, really likes to bind to your muscarinic 2s. So if I were to bind the beta 1s with norepinephrine, I would have positive chronotropy, dromotropy, inotropy, lusitropy. So, you know, chronotropy, contractility. Oh, I don't remember. Oh my God. I know I have them in the little bottom, like the little note section. Inotropy is like strength of the contraction. How intense is it contracting? Lusitropy, I think, is like how intense it's relaxing, I think. It's in the notes. Not that important. But notice that if you stimulate the M2s, it's going to inhibit these effects. So again, kind of the nervous system kind of plays on what it wants the heart to do. And then over here, we're going to talk about this a little bit later, but this is, again, like in a specific cardiac myocyte. You can also have, this is basically just showing how you can have calcium leave the sarcoplasmic reticulum to actually help with the increased inotropy. It's just showing, you know, actual, like, how are you increasing inotropy? So more alpha 1s. So these are located on both arteries and veins. So you can already hear the questions, right? So if I'm stimulating an alpha 1 on the arteries, you're going to get vasoconstriction. But if you stimulate alpha 1s on the veins, you're going to get venoconstriction. So it's like almost the exact two opposite things are happening there. Okay. So alpha 1s are on both. These are G alpha Q coupled, so GQs. So that's going to increase IP3DAG. Those are the second messengers for your GPCR system, as well as calcium plays a big role. These are also under sympathetic control, epinephrine, norepinephrine. So if you bind to alpha 1, you get vasoconstriction. If you constrict the arteries, you get increased TPR, SVR. If you constrict the veins, you're going to basically put more more blood that's in the venous system back into the heart. So you're going to increase your preload. And altogether, if I'm increasing my total peripheral resistance, I'm increasing afterload, and I'm increasing preload, I'm going to basically increase my cardiac output. And this is a really important concept when it comes to RAAS and heart failure, which we're going to talk about later. So just keep this in mind that like if you stimulate an alpha-1, you're getting vasoconstriction. You're also getting venoconstriction, but vasoconstriction is like what you typically should think about when you think like when you hear alpha-1. If you inhibit alpha-1, so you give like an alpha-1 receptor blocker, you get vasodilation. This is a GPCR, super low yield. I debated putting this slide in, but I did want to tell you guys about these because these will come up second year. I would bet money you do not need to know these for first year. There's pharm medications for like heart failure, for hypertension that are basically dopamine agonists and antagonists. So dopamine receptors also do kind of play a role in the heart. If you stimulate either one of them, you can have like changes in your blood pressure. You can like vasodilate, whatever. So that's what I put here. I just put like very basics. Your dopamine 1 receptors are GS coupled, dopamine 2 is GI coupled. And again, it's just, they exist. Just know that they exist. And again, they can help you with hypertension. There's also histamine receptors located on the blood vessels, also like a low yield concept that are also GPCRs. Okay, but super low yield. You'll do them next year. Okay, so what is the baroreceptor reflex? The baroreceptor reflex, baroreflex, baro means pressure. So this is a negative feedback loop. Basically, the baroreceptor reflex is to maintain homeostasis at all times. And it's really important to remember it's homeostatic, meaning that like it kind of like whatever your homeostasis is what it's trying to do. So, and we'll talk about this, but this is basically why, people that have super low blood pressures aren't passing out all the time because their baroreceptor reflex has like learned that's what their homeostasis is. That's what they are like trying to control the blood pressure to, if that makes sense. But they basically are stretch receptors. I know they're technically pressure sensors, but they're stretch receptors because they fire based on stretch on the wall. And I did mention this last time because I was like, we're going to talk about these probably. But where are baroreceptors in the body? So they're in the carotid sinuses and they're also in the aortic arch. So then just asking some anatomy, the 3 branches of the aorta. So hopefully you guys are thinking about this and saying all 3 branches in your head, but the brachiocephalic trunk, left common carotid, left subclavian. Please know the 3 branches of the aorta. Okay, so that's basically where you can find baroreceptors within the body. So here's like a very rough schematic. I even put over here, like this is technically not where carotid baroreceptors are located. I just wanted you to kind of see it with, one image just to get an idea. Technically, they're located where the common carotids bifurcate. So each common carotid is going to bifurcate from like, external and internal carotids. That's where they're located, but it's the same idea. And then your aortic baroreceptors are located in the arch of the aorta. Okay, so here's a better picture. So here's your carotid sinus, bifurcation of external and internal carotids. So these are afferent pathways back to the brain. So afferent meaning that it's like, you'll kind of go into this a little bit more with neuro, but when you have like afferent fibers versus efferent fibers, afferent is kind of like what's sensing what's going on and sending it to the brain. And then the brain sends efferent fibers out. And it's like, okay, now do what, like, now this is how I want to respond to what you're sensing. So like afferent is going towards, efferent is going away from the brain. And so basically the carotid, and this is kind of what I mentioned in the anatomy session as well, the carotid baroreceptors, they kind of go along with cranial nerve 9. So what cranial nerve is this? Hopefully in your heads from last time, you're like, okay, that's the glossopharyngeal nerve. So they can say cranial nerve 9, 1X is 9 in Roman numerals, glossopharyngeal, these are all the same thing. Another weird thing is that if you see the term Herring's nerve, this is the same thing as the carotid sinus nerve. It's just like it's like a Clubunde like thing that he says a lot. But if you see Herring's nerve, that's what they're talking about. And then the aortic baroreceptors kind of course along with cranial nerve 10 or cranial nerve X, which is 10 in Roman numerals. And then hopefully you guys are saying, okay, that's the vagus nerve. So these are all kind of interchangeable. So you definitely should know those because they will use those interchangeably when talking about baroreceptors. But this is how it works. So kind of like to think about baroreceptors, we have to think about this equation. So yes, first year is all about equations. So they do make a comeback always. But if you think about change in pressure, equals resistance times, sorry, blood flow times resistance, right? So if you want to kind of change this up, or not change it up, but if you kind of want to think about how else you can think about what blood flow means, blood flow technically equals your stroke volume times your heart rate, right? So you can even think about any of these changes. So if you change stroke volume, if you change heart rate, if you change resistance, you're going to change blood pressure. So this is kind of what your baroreceptors are super, super like sensitive to. So for example, if your normal blood pressure is 120/80, like this is your normal blood pressure. Let's say 120/80 means that every minute these baroreceptors are firing 10 action potentials per minute. This is a run. I just made this up. I completely made this up. So don't like memorize 10, 35, made this up. Let's just say it's 10. Like this is what the brain is used to receiving for this person's blood pressure, normally 120/80. So the brain says, okay, this is normal, so it's not going to respond. This is this person's homeostasis, blood pressure homeostasis. Now let's say that something happens and the blood pressure goes to 140/90. Something happens. Now you're sending 30 action potentials per minute. The brain's like, wow, that's very high. That is a lot higher than I am expecting. Like, it doesn't need to be that high. We need to get back to the normal. So it's going to respond with a parasympathetic response, which I'll go into and kind of show what that's going to look like. And then let's say you have lower blood pressure, so about 90/60, something like that. So now the baroreceptors are only firing about 5 action potentials per minute. The brain interprets this as being really low, so it needs to be like, we need to increase the blood pressure. So it stimulates a sympathetic response. So kind of to talk about like how it maintains homeostasis, I have the carotid baroreceptors here and the carotid bifurcations. I have the aortic arch baroreceptors here. Remember, the carotids course along the afferents of cranial nerve 9. Aortic arch courses along with the vagus nerve. These are the afferents, so these are going towards the brain. They go to a location of the brain called the NTS, or the nucleus tractus solitarius. I know that sounds like an absolutely wild name. You're going to learn all sorts of wild stuff in neuro. This is just something to just know for now. I hate saying that because you're like, but you'll go into it plenty when you get to neuro. This is just like in the brainstem, this is the center for these two cranial nerves, is the nucleus tractus solitarius. Okay. So then the NTS, this is what's like this is where the brain is interpreting high, low, normal. And then depending on what it's interpreting, then it's going to either be like, okay, let's send out a parasympathetic response or let's send out a sympathetic response. And then it's going to affect the heart to kind of change to make sure that the pressure goes back to normal. Okay? And then these little black arrows are going to be the action potentials. All right, so let's talk about baroreceptors like with someone that has an increased blood pressure. Okay. So with increased blood pressure, the walls of the carotid arteries and the aorta are stretched more than normal, right? So they're going to be stretched more than normal because, again, if blood pressure goes up, that means there's going to be more blood here. And again, like I said, baroreceptors are kind of like stretch receptors. So if the blood pressure goes up, the stretch on the wall goes up. So they're going to sense that. So now what they're doing is they're firing at a higher than normal rate. So you can notice back here on this slide, this is the normal for this person. It's like, it should be 10. I didn't count the arrows, but it should be like 10 action potentials every minute. Now it's like 30 action potentials every minute. So it's firing a lot more than it should. So basically, what the body wants to do, so now the NTS senses this, and what the body wants to do is it wants the pressure to decrease. It's like, hey, this is way too high. Let's go back to your normal. So what it's basically going to do is it's going to try to decrease the flow. So if it's decreasing blood flow, how it can decrease blood flow is it can decrease stroke volume, it can decrease heart rate, it can do any of those. It can also decrease resistance, any of those to kind of bring pressure back down. So what it does is it stops the sympathetic nervous system from working. So it puts a little red light on the sympathetic nervous system, and it stimulates the parasympathetic nervous system. When it activates the parasympathetic nervous system, remember we talked about acetylcholine very briefly. Acetylcholine is going to work on the heart, and it's going to decrease your heart rate. Remember, it binds those M2 receptors, and it's going to cause a decrease of heart rate. It's going to basically do the opposite of what your epinephrine, norepinephrine do. It also is going to cause vasodilation, so it's going to decrease the SVR, TPR. And again, it's just trying to play along with these things in this equation. It's trying to decrease as many of these things as possible to bring the pressure back down. Okay? How about if your blood pressure decreases? If your blood pressure decreases, now the walls stretch less than normal, so now they're firing at a lower than normal rate. And if that happens, the brain's like, wow, we need to get this up higher. So it's going to stop the parasympathetic nervous system, and it's going to activate your sympathetic nervous system. Sympathetic nervous system, norepinephrine, epinephrine. Those are the two you should be thinking of. It wants pressure to increase. So it's like, all right, let's play with blood flow and let's play with resistance. So playing with blood flow, it's going to increase your stroke volume and your heart rate. So norepinephrine, and we're going to talk about this with shock, but norepinephrine increases heart rate. It directly binds to your beta-1 receptors on the nodal cells, and it also helps to increase stroke volume. It binds to beta-1 receptors on the contractile cells. And again, we're going to talk about this later. It can also increase resistance. So this is again why, like, technically when you're exercising, you get vasoconstriction of your arteries, and everyone gets confused and they're like, that makes absolutely no sense. But remember that you release local metabolites when you exercise. So you release things like AMP, adenosine, things that are going to cause vasodilation. That like kind of overcomes and causes vasodilation. We can talk about exercise later. Where does acetylcholine bind in blood vessels? Acetylcholine, I want to say M1, but it could be like M2, or it could be from just inhibiting alpha-1 as well. Yes, exactly. So you're also directly inhibiting sympathetic stimulation here. So technically you're getting less alpha-1. Yes, exactly. It's a good question. I don't exactly know if it's M2 on the vessels, but definitely M2 in the heart. But also, yes, not having alpha-1, it's also going to affect the vasodilation. Okay, all right. Cool, all right. So, oh my God, okay. Other important things to understand, because this is really going to play into shock. And I'm kind of really dragging this out because when you get to shock, we're going to be like, boom, boom, boom. And you're going to be like, wow, this makes all so much sense. It comes together. So the other really important thing to understand, and this is why the baroreceptor reflex doesn't save you when someone's like has a heart attack, or someone has like hemorrhagic shock, or they have cardiogenic shock. The baroreceptor reflex doesn't really help that because this is a very just rapid response. It's a reflex, right? It's a baroreceptor reflex. Very short term. So short term to the point where, like, when you guys are laying down in bed and you are laying down in bed for 8 hours, who are we kidding? 5 hours. And then you get up out of bed, you don't immediately pass out because all that blood is technically like in your veins. Why do you not immediately pass out? And it's because that's how quickly the baroreceptor reflex is working. It's working that quickly to make sure that your blood pressure stays up. Another thing to know is that the baroreceptor reflex can basically like adjust. So it can basically it can have a new set point if it needs to. So high or low potentiation of blood pressure. If you have really high blood pressure and that's just your normal, or if you have really low blood pressure and that's just your normal, the baroreceptor reflex will actually like reset. So like before, when I had like 120/80, this is this person's normal. Maybe your normal's 90/60, or maybe your normal's 130/85. I don't know. It can adjust, and then it can kind of go off of, okay, if it's higher than this, then we're going to respond. If it's lower than this, then we're going to respond. And again, this is what I was saying earlier, why people that have really low blood pressures aren't just passing out all the time. Like, it's because the baroreceptor reflex has like adequately like adjusted to this person's homeostasis. Okay. So basically, how does RAAS kind of fit into the baroreceptor reflex? So we're going to talk about RAAS in the context of shock. And then this is exactly what heart failure is. So shock in general is when they say someone has shock, any type of shock, any of these 4 types of shock, the end result is always decreased oxygen delivery to the tissues. So it's kind of like a hypoxia. Shock is basically hypoxia. Usually it's because of like not enough blood, because again, that's how the organs get oxygen. But and like we'll talk about, it doesn't really apply here, but when we talk about distributive shock, like an immunoblock, that's technically like it is a blood issue, but it's like the tissues aren't getting oxygen and then they freak out, and that's when all hell breaks loose, basically. Hypovolemic shock and cardiogenic shock are the 2 most important for your exam. I'm specifically going to be focusing on hypovolemic to talk about RAAS because I think that's the easiest to kind of grasp what RAAS does, and then we'll go into cardiogenic when we talk about heart failure. I wanted to put on here too obstructive shock, a tamponade, cardiac tamponade. actually is an example of obstructive shock, but it's exactly the same as cardiogenic. It's just like, I'll bring it up when we talk about it, but obstructive shock can come up on your exam as well. But distributive is like totally different. It's like an entirely different symptoms even is distributive shock. So that's not going to be on your exam. So these three, I would say. So again, shock, you can kind of think of the pathophys of this is inadequate tissue perfusion. So again, not enough oxygen is getting to the tissues. So the tissues basically die. So they undergo ischemia and then eventually they die off. They undergo necrosis. So if you don't reverse this at one of these steps, that's when you can get multiple organ failure. And that's when it's like, oh, someone died of shock or someone is going into shock. They're like, all their organs are like not working. So here's kind of like a picture of like, the arteries, the veins, and then the capillaries in the middle. Usually when you have decreased tissue perfusion, it's usually when you have a drop in blood pressure. And again, I put for some reason, it can be anything. You're bleeding out, your blood pressure drops like insanely, you have a heart attack, something happens where your blood pressure drops. Because again, if the pressure drops here, like again, if we have a normal baroreceptor reflex and we have our patients establish homeostasis, these tissues are expecting to get a certain amount of oxygen at all times and expecting to give off like its byproducts of carbon dioxide at all times. It's expecting this to happen all the time. And this is what I was talking about too with like the anatomy with like certain types of like, well, like maybe we didn't really talk about it, but like certain types of like if you have angina or something where it's like if the tissues start to, if you have chest pain, it's because the heart is like, it doesn't have enough oxygen and it's like, oh my God, I need more oxygen. Like I'm just used to a certain amount of oxygen. This is kind of the same thing. It's kind of like these tissues are used to a certain amount of oxygen. And once they don't get it and you can't compensate, that's when it's like, that's when you can kind of go into shock. So basically, how does a fall in blood pressure lead to shock? Equations. So here we go. So if you remember, blood pressure is basically resistance times cardiac output. Cardiac output is basically heart rate times stroke volume. Stroke volume is end diastolic volume, well, left ventricular end diastolic volume minus left ventricular end systolic volume. So you think of end diastolic volume, volume left after filling, minus the volume left after contracting. So if you can see here, what can cause a drop in blood pressure is a drop in any of these things. And that's, again, what kind of makes like heart failure shock a little confusing because it's like the cause can be anything that affects anything in all of these equations. Okay, so I'm going to give you guys some examples. So hypovolemic shock, hypo, low, volemia, volume of fluid. So basically hypovolemic shock, shock induced by low blood volume. So it can be hemorrhagic or non-hemorrhagic. Hemorrhagic means, because again, it's the volume of fluid in the blood. I know you guys haven't had heme. Heme's like second year. But basically blood is not all just red blood cells. It's also like plasma, and there's also like white blood cells in there. So if you have hemorrhagic shock, this is like your blood, like you're losing blood, like physical blood. So I gave you guys some examples here, a GI bleed, trauma. Usually this is like, car accident patient, they're being rushed, when you see it on like TV shows, they're being rushed into the hospital. It's like, they're going into shock. It's usually because they're bleeding out. Postpartum hemorrhage, ectopic pregnancy, hemoptysis. This one always gets me. I'm like, coughing up blood can go into shock. But it can. You don't need to get rid of that much blood to go into shock. You can also have non-hemorrhagic shock. So this would be like a non-blood fluid loss. So this would be like you're just losing fluids. So like a third-degree burn, really good example of like a hypovolemic shock. Vomiting, diarrhea, bowel obstructions, pancreatitis, diabetic ketoacidosis. I would say for like, this is going to focus more on hemorrhagic, but just note that it's like you don't just have to be bleeding out to go into shock. You can like also have really bad diarrhea for like a week, and then you can technically go into shock because you're losing that much fluid. So quick example, hypovolemic shock due to blood loss. So like something like a motorcycle accident, car accident, something that you see, a trauma. So what's going on? You're losing tons and tons of blood. So what's that going to look like? That's going to look like you're absolutely decreasing preload. Can't burns lead to sepsis, a type of distributive shock? Very good question. This is actually what my PhD is in. It's in sepsis. We will talk about this in immuno. Distributive shock is basically, that's how sepsis kills people, is through distributive shock. That is a totally different kind of pathology state. Luckily, you don't have to know it for this exam, which is great because it's like, again, we're going to talk about like different, arrow questions, like, oh, what happens to preload? What happens to afterload? Those types of like, it goes up, it goes down. You don't have to worry about distributive, which is really nice. Distributive is going to be more so, again, with immunoblock. Okay. But yes, burns absolutely can lead to sepsis, 100%, but it is because of that shock. That's what ends up killing people. Yeah, no problem. Okay, so with this, you're losing tons and tons of blood. Preload goes down. So if we follow the little arrows back up, that means stroke volume has to go down. If preload's going down, stroke volume's going down. If stroke volume goes down, cardiac output goes down. If cardiac output goes down, my blood pressure goes down. So basically, you get a decrease in blood pressure all because you have a decrease in preload from losing this blood. How does the body compensate? The body compensates first, baroreceptors kick in, right? This happens super, super, super quickly. They're like, all right, I'm going to come into play. I'm going to release epinephrine, norepinephrine. And you're like, wow, okay, I'm going to cause venoconstriction. So I'm going to venoconstrict the vein. So I'm going to try and increase preload. Remember I said that helps increase preload. If I increase preload, that should increase stroke volume. That should increase cardiac output. It can also increase SVR, TPR, whatever. It can also do that because remember, epinephrine combined to alpha-1 receptors, which can cause vasoconstriction. And then ultimately, it can increase your blood pressure. Great. You're like, wow, I'm done. Like, the body fixed me. Like, I'm bleeding out from a motorcycle accident. I'm not like, I'm good. But baroreceptors, again, they are a short-term response to something. Again, you're laying down, you get up. They're not meant for this life. They're really not meant for this lifestyle. This person can't, basically, they need more volume. They need to make up for this massive loss of volume. So baroreceptors initially are going to be like really helpful, but they're like, okay, like that's all I can do. You need more fluid. Like that's what you need. That's where RAAS kind of kicks in. So the baroreceptors do kick in all the time with shock. You'll see it too with like heart failure, the baroreceptors kick in. But RAAS ultimately needs to come into play to basically save this person. Okay? So what does RAAS do? So basically the kidneys are going to sense this decreased blood pressure. So they call this like, it's a decreased renal perfusion. It's basically the kidneys seeing really low blood volume than what they're used to. And then they release renin, angiotensin, aldosterone, ADH gets released as well, which we're going to go into a lot of detail about. So this is the detail. So this is kind of what's happening. So I tried to make this as least as confusing as possible, but anything in blue, this is going to be your venous system. So this is like the inferior vena cava into the right side of the heart. So I have the right ventricle here. I have the lungs, and then I have the arterial system over here. So the left ventricle, your aorta, where all the baroreceptors would be, and then back to the tissues, and then kind of like this cycle. So, you know, if the human body is not this simple, but if it were, this is how I'm going to explain RAAS. And then the kidneys are over here, the adrenal glands are over here, and the pituitary gland is like up in the brain. Okay, so the first thing that happens is your blood pressure drops. Your baroreceptors are first on the scene. They are basically going to sense this decrease in blood pressure and go to the NTS. So your carotid baroreceptors, your aortic baroreceptors are going to go to the NTS. Actually, that's why I did that. Your aortic baroreceptors do not, this is just like a fact. I don't know how important it is to know. I don't want to say not to know it, but the aortic baroreceptors don't sense decreased blood pressure for whatever reason. They just don't sense decreases in blood pressure. The carotid baroreceptors sense decreases and increases. Okay, so your aortic baroreceptors only sense increases in blood pressure. Your carotid sense both. I think that's why I only put the one line from the carotids here. Okay, again, it's just like a random fact. Okay, so the carotid baroreceptors go to the NTS. The NTS is like, okay, blood pressure dropped. Let's stimulate the sympathetic nervous system. Let's release some norepinephrine, epinephrine. So it releases norepinephrine. What does norepinephrine do? It binds to alpha-1 receptors, causes vasoconstriction. It binds to beta-1 receptors located on the nodal cells, which are located in the SA node. So then you go on the right side of the heart, which is going to increase your heart rate. And they also bind to beta-1 receptors in the myocardial cells, so they're going to help increase contractility. Also, the kidneys now, so again, that's kind of what the baroreceptor reflex, that's all it can do. But again, this person, it can't just magically make more fluid. It still needs to increase its fluid. And so that's where the kidneys are going to kind of come in. They're going to sense this decreased renal perfusion, secrete renin. Renin converts angiotensin into angiotensin 1. Angiotensin 1 gets converted to angiotensin 2 by ACE or angiotensin converting enzyme. And then pretty much everything else is going to be because of angiotensin 2. Angiotensin 2 is like the guy. He's the guy. So what does angiotensin 2 do? First, it binds to angiotensin receptors located on the arteries. Really confusing. I'm going to talk about it a little bit later, but angiotensin 2 receptors are called AT1 receptors. makes absolutely no sense. I don't know. I think they did that on purpose to mess with us. But AT1 receptors, if you see this, these are your angiotensin 2 receptors. Really annoying, even though it's one. Okay, so, but they have the same effect as an alpha 1 receptor would. So if you bind to an angiotensin receptor, it's going to cause vasoconstriction. Okay. Another thing that it does is it goes to the pituitary gland up in the brain. And the extent, I know it's like a neuro thing, but the extent of understanding angiotensin 2 binding to the pituitary gland, all you need to know is that it, one, causes the release of ADH, aka vasopressin, and two, it causes you to get really thirsty. So again, that's why they say like, oh, if you're thirsty, that means you're already dehydrated. That's kind of where this comes from. It's like if you're stimulated to like drink, it's like, oh, your body's like, you need some more fluids type of thing. So it stimulates ADH release and it stimulates you to be thirsty. Do AT1 receptors use GQ signaling? I don't believe angiotensin 1 receptors are G protein coupled receptors. I don't believe they are, but they act exactly the same way. So you still will get vasoconstriction. No problem. Okay, so then angiotensin 2 also goes to your adrenal glands, stimulates the adrenal glands to release aldosterone. You'll go into way more of the specifics in endo. Aldosterone is a hormone that's going to go to the kidneys along with ADH, and it's going to basically cause you to reabsorb both salt and water. So sodium reabsorption and water reabsorption. By doing all of this, that's going to now increase your fluid in the body, which should increase your blood pressure. Okay? So AT2 binds to AT1 receptors, right? Yep. Don't you love it? Don't you love medicine being super confusing? Yes. Yeah, so AT2 binds to AT1. Makes absolutely no sense. But AT1 is an angiotensin 2 receptor. Makes no sense. Okay. Yeah, love to see it. Love to see lots of stuff in medicine. You guys just wait. It gets even worse. But so this complicated thing is RAAS. But the whole point of RAAS, and again, that's why I went into the details before, you're just trying to get what they think is happening, this drop in blood pressure, increase in any way that they can. They want to increase your stroke volume. They want to increase your contractility. They want to increase your fluid. They want to increase everything possible that it can to get your blood pressure back up. Here's like the picture from Costanzo, and the classic question that people always ask is like, does this happen all at once? So does this happen like immediately? The short answer is kind of. So like it kind of happens all at once, but the things to remember is that renin is a hormone. So when it has like decreased renal perfusion pressure and then the release of renin, hormones, and again, I know you guys didn't go into, you haven't had endo yet, but something you should understand about hormones is hormones take a little bit longer to be produced. And the reason why is like when you want to make a hormone, you have to go and turn on transcription of these cells. You need to go to like the DNA of these cells and make a transcript, go translation, go. So it's like it takes a little bit of time. It's not like it takes weeks, but it takes a little bit of time to make renin. So I say like this process has to be turned on, so it can take anywhere from 1 to 2 days. This still happens kind of quickly. But that's why, again, people, if you're like, well, why doesn't RAAS then save people that like, get in car accidents? That's why it doesn't work quick enough for those types of people. But when this becomes important is when we're going to talk about heart failure pathology, which we're going to talk about at the end. Oh, thank you. Okay. So AT1 receptors are GQ protein coupled receptors. I think you're probably right. It's such a small detail. They usually focus more so on your true G protein coupled receptors, which would be in that PowerPoint, the ones that they will usually ask about. But yes, they worked exactly the same way. So good to know. Now they're GQ coupled. Renin was an enzyme. Yeah, yes. Well, technically it is an enzyme. Just like ACE is technically an enzyme, but it's still it's a hormone. So it's considered a renal hormone that gets because a hormone is just a general. And again, I know we haven't gone into endo yet. A hormone is just anything that gets made by going to the DNA and turning on like transcription of that. That's a hormone. So then once it is made, yes, then it's going to act as its as an enzyme to convert, because you need an enzyme to convert angiotensinogen to angiotensin 1. 100% renin is an enzyme, just like your ACE is an enzyme. And that's what's interesting about the COVID virus. Coronaviruses bind to ACE. So like when it's like, oh, coronaviruses bind to its receptor, it's binding to ACE, which is an enzyme. So it's really weird. It's terminology. It really is terminology. Technically, for COVID, ACE is a receptor, but technically it's an enzyme. Just like renin, same thing. It's a hormone, but it's also an enzyme. Yes, veins also have alpha 1. So you will have also venoconstriction. I just more so put on anything that's like, that can go into the equation. But yes, veins also have alpha 1. Norepinephrine will bind to alpha 1 and also stimulate venoconstriction as well. Yep. When that's kind of why in the beginning when I had like the definitions, alpha 1 binding to, no, what is it? Norepinephrine binding to alpha 1 on veins and arteries. All that's trying to do is decrease the stress volume. You're trying to basically just get more blood back to the heart. So stress volume, we're trying to get it out of the arterial system, get it back to the heart. Okay, so that's why you're vasoconstricting as well as venoconstricting. Okay. Love the questions. Keep them coming because like this stuff, like if you get it now, heart failure, you're gonna be like, wow, that is super, I got it. All right, other things to know about hypovolemic shock, because it'll help you with vignettes, is hypovolemic shock is considered a cold shock. Actually, the first three, so hypovolemic, cardiogenic, and obstructive, they're all considered cold shock. Meaning if you literally touch this person, their skin, it's going to feel cold. The reason why, they're losing blood, they're losing fluid, you can't regulate internal body temperature. That's endo block. You'll go into that more. If you know anyone that has hypothyroidism, they're always cold. It's kind of the same concept. You can't regulate internal body temperature. They're going to have cyanosis because preload goes down. So then so you might see some cyanosis, especially like on their fingers and toes. Metabolic acidosis, I'll talk about why you get metabolic acidosis. And then with CBCs, so if you do a CBC, again, I know you haven't had heme yet, but you're going to see high hematocrit if you have non-hemorrhagic shock and low hematocrit if you have hemorrhagic shock. And I really just put this here, again, because sometimes questions will give you a CBC, and I don't want you to be like, why are they giving me a CBC? They're probably just trying to show you if it's like hypovolemic shock, they want you to see what the hematocrit is. So if you have non-hemorrhagic shock, remember, you're not losing blood cells, you're losing plasma volume. So you're losing this part here. So if, let's say you lose just, you lose this much from here. So you go from this much to now only this much. Hematocrit is basically how much of the total blood do you have is red blood cells. So how much of the absolute total, so how much of this total is red blood cells. So normally it should be around 30 something ish. I forget what the normal hematocrit is. I think it's like 30 something. But if you have increased hematocrit, so something that would happen with non-hemorrhagic shock where you're not losing blood, but you're losing like plasma and volume, you'll see a high hematocrit. So overall, there's more red blood cells than there basically should be. A low hematocrit, this is if you're like bleeding out, that's when you have less red blood cells than you should. Okay, so again, just more so wanted you guys to be aware of if they give you a CBC, that's why they're giving you a CBC. Metabolic acidosis, why does it lead to shock? So I'll talk about, it's actually, I think it's the opposite. I think shock leads to metabolic acidosis. I'll talk about, I have a little picture to show you. But, so treatment. With this, you want to restore blood volume. So again, that's the whole problem, is you don't have enough fluids. So that's why a lot of the times you're basically putting fluids in these patients that come in. You give them blood transfusions, you could just give them normal saline, you just want them to get fluids, and you also want to watch for hypothermia. So remember, they can't regulate their own body temperature. So again, remember, if you see trauma side of the road, people get wrapped up in blankets. That's why they can't, if they're bleeding out, they're not going to be able to control their own body temperature. So you want to be able to keep them as warm as possible. Okay. Can you explain why low hematocrit and hemorrhagic? So low hematocrit and hemorrhagic shock. So with hemorrhagic shock, that's like you're physically losing blood, like the blood cells. So like this red part. So kind of like you said, like, yeah, you can have interstitial fluid moving into the blood. You're just going to have, it's like a relative thing. Like you're going to have relatively, therefore, more fluid than blood, just relatively speaking, because there's just not enough red blood cells. So like, there's just more fluid there now. So that's why hematocrit goes down, is because now there's just more fluid compared to the amount of red blood cells. So it's not really like the interstitial fluid, like there is differences with like the hemostatic or the hydrostatic and the oncotic pressures can kind of be affected. But usually it's really just like a relative thing. Like there's less red blood cells compared to what it normally should be. So that's why it's like a lower hematocrit. But hydrostatic pressure kind of plays a little bit more of a role for heart failure, and that's actually why you can see edema, but we'll talk about that later. Okay, so that's hemorrhagic shock. Cardiogenic shock, and again, this is essentially heart failure. So when we talk about heart failure later, I'm going to fly through it because it's basically just cardiogenic shock. So cardiogenic shock, I want you to think about with cardiogenic shock is the same thing, shock. So decreased tissue perfusion of oxygen induced by the heart being unable to generate enough power. Cardiogenic, it's like the heart can't generate enough power. So something happened to the heart, now it can't pump enough blood to the body's tissues. Again, usually this is going to be like your heart failure, but it's like what causes heart failure kind of thing. So anything that affects pumping up the heart. So an acute MI, a pericardial effusion, myocarditis, aortic stenosis, any of these things can cause cardiogenic shock. You don't even have to memorize this list. Just kind of if you understand like, oh yeah, an MI, the heart's not going to be able to pump as nicely, that's going to affect the pumping power of the heart, basically. And then if we look at our little thing here, so what's going on? I have a sudden heart attack. So like let's say we have an acute MI. There's ischemia to the area, the cardiomyocytes die. Now we're going to start having weaker contractions. So if I'm having weaker contractions, my stroke volume goes down. If my stroke volume goes down, my cardiac output goes down. If my cardiac output goes down, my blood pressure goes down. What does the body do to compensate? The baroreceptors kick in. So your baroreceptors kick in, it releases norepinephrine. This is a vasoconstrictor. It's going to increase your heart rate. As we talked about, yes, it also venoconstricts. So you can think about it as it also increases your end diastolic volume a little bit. So that will also play a role here. Your heart rate's going to go up, which is going to increase your cardiac output, which is going to increase your blood pressure. You're going to get vasoconstriction, which will increase your resistance. And then hopefully blood pressure should go up when you have something like an acute MI. And then this is kind of like, I feel like power indicates an electrical issue. Would it be more appropriate to say decreased stroke volume? Not trying to be picky, I just want to make sure. Yeah, that's fine. That's fine. If you think power, like if you associate power with like electricity, then don't think about that. Think about it as in terms of like stroke volume for sure. Okay. So yeah, so that's fine. Technically, power is just like how much work the heart is doing, but whatever works for you, seriously. So if you're thinking electrical, don't think about power, stroke volume, because that technically is what the issue is a low stroke volume. Cardiac tamponade not be cardiogenic. I always see different sources with cardiac tamponade. I actually think I had it in the last slide for cardiogenic shock, but technically it's obstructive shock. Obstructive shock, I tend to think about more of like a pulmonary embolism or, like a PE or a pneumothorax, something. Obstructive shock is like a physical obstruction. So like you can't get blood out. Cardiac tamponade technically is cardiogenic shock, but technically it also can be cardiogenic because again, with cardiac tamponade around the heart, we have this sac with tons of fluid in it. Now when the heart's beating, it's not beating as well. So technically, yeah, like you're not getting as much blood out. But in tamponade, technically it's like it's reducing how much the heart is beating to the point where it's almost like there is an obstruction. It's like one of those like definition things that it's like not super important. That's why I was like, whatever. But you can kind of think of cardiogenic shock and obstructive shock are the exact same things, like in terms of like their pathophys. It's just what's causing them differs, but they're the exact same thing. So if you think about it as one or the other, it's still gonna be like the right answer. Okay. Could an electrical issue lead to cardiogenic shock? Yeah, well, yeah, exactly. Yeah. So if you have like a heart attack, then the heart goes into like an arrhythmia, which we'll talk about arrhythmias like in a future session. If your heart's in an arrhythmia, technically it's gonna like stop working correctly. The organs are not getting perfused with oxygen, and then you can undergo shock. Yeah, for sure. Yep. It's just so it can lead to it. It's just I'm not really talking about arrhythmias here. This is like your true cardiogenic shock, like something happened to the heart so it can't pump. Like a heart attack for sure. Yes, amazing. Oh, that's beautiful. Thank you, Lauren. So she goes for my recording. Cardiogenic, the heart has a pump, doesn't work. Obstructive, if you remove the obstruction, the heart works. So again, something like tamponade. Technically, yeah, it's cardiogenic, but it's like if you take out that fluid, it's going to be fine again. You remove the obstruction, it starts working again. That's kind of said it better myself. That's perfect. Yes. So exactly, like again, but again, it's the same thing, the same pathophys, just kind of like, yeah, semantics. But all right, good. Okay, so cardiogenic shock. Remember, the first thing is decreased stroke volume, decreased cardiac output. The heart can't pump, decreased heart pumping. So what's basically going to happen is now we have blood that's circulating a lot slow, like a lot less than it should. You can think of these arrows as like those action potentials, like it's less than it should. It's like lower oxygen than it should. So when it gets to the organs, this is decreased like circulating blood volume. These tissues are expecting a certain amount of oxygen at all times. If they're not getting it, they're going to be upset. Yeah, so this is your hypoxemic hypoxia. So throwback to poem, but hypoxemic hypoxia is because there's hypoxia, that's decreased oxygen delivery, and it's hypoxemic because now there's less oxygen in general. So these tissues now have less oxygen. And so what they're going to do, and this is how metabolic acidosis ties into it, they're going to, since they have less oxygen in general, they're going to shift from undergoing aerobic respiration to anaerobic respiration. So anaerobic respiration, you guys will have your biochem review in GI block. But very briefly, anaerobic respiration, you have decreased ATP, but you have more lactic acid. And when you have more lactic acid, this is bad. It can dissociate, it can give off proteins, and then you can undergo metabolic acidosis. So it's basically like a non-anion gap it's an anion gap metabolic acidosis. And this is going to by having a metabolic acidosis, it can actually further depress cardiac contractility. Okay, so metabolic acidosis, not good, actually makes things a lot worse. But this is what's happening because the tissues now shift from this aerobic respiration to anaerobic respiration. So kind of what the body tries to do to compensate for something like this is they're going to release RAAS, which is going to increase your systemic vascular resistance as well as increase your heart rate. They're trying to basically compensate for what the problem is. Okay, so cardiogenic shock, like I said, this is also a cold shock. You touch the patient, they would be cold. And then this is a very, very common cause of death in an acute MI, kind of like what we talked about. You have an acute MI, and then the heart can't pump well, so it undergoes shock. So I wanted to bring back a coronary artery angiogram, because we talked about that last time. So I was gonna have you guys guess what artery this was, but didn't want to be mean. But this is the LAD. So you can see here this crazy stenosis in this LAD. So instead of looking nice and like straight like this, it looks like that. Then it kind of indents and keeps going. That's your stenosis in this person's LAD. So this is a patient that had an acute anterolateral MI who developed cardiogenic shock. So this is your severe stenosis of the LAD. And then my kind of little anatomy plug here is what other artery supplies the anterolateral papillary muscle. So the anterolateral, the LAD, left anterior descending, lateral, the LCX also supplies the anterolateral papillary muscle. The posterior papillary muscle is supplied by the RCA. Okay. Just a throwback to anatomy. So how do you treat these patients? Something that people don't think about is you put the patient on oxygen. Again, they're undergoing lactic acidosis. They have metabolic acidosis. You want to make sure that you give them oxygen so that they can shift back to aerobic respiration. Then you want to put the patient on a vasopressor. So vasopressor is usually going to be something that's going to cause vasoconstriction. So some like relevant tie-ins like that were on your little syllabus, your like the little pharm area of the syllabus, norepinephrine, dobutamine, milrinone. So norepinephrine, this is a positive inotrope. It's a beta agonist, so it's going to help the heart pump better. It's going to bind to beta receptors and stimulate those. Dobutamine is kind of the same thing. And then milrinone, I'm going to talk about milrinone on the next slide, but this is an example of a phosphodiesterase inhibitor. So phosphodiesterase inhibitor is going to cause vasodilation, which you'll see. Vasoconstriction, which you'll see. And then other than that, you treat the underlying cause. So what's causing this cardiogenic shock? Try and treat it. Wouldn't a vasopressor decrease RBF? renal blood flow, right? RBF. Yes, technically it will decrease renal blood flow. Yes. But at this point, it's kind of like you need to increase the blood pressure. Like that's more important at this point. The kidneys are already going to release RAAS. Like they're already sensing this decrease in blood flow. So they're going to do RAAS, but in the meantime, yes, prostaglandins play a role too. Yes, absolutely. But in the meantime, what these guys are trying to do is just increase the blood pressure. Like they're just trying to do the you're just trying to increase the blood pressure because these are drugs that you're giving the patient. So it's like let's just try and get the blood pressure up in the meantime and let's kind of stabilize this patient. Okay, so here's milrinone. So I know you guys had on your thing like phosphodiesterase 3 and phosphodiesterase 5 inhibitors. So this is milrinone is a phosphodiesterase 3 inhibitor. So to kind of understand what a phosphodiesterase inhibitor is, it's again a G protein coupled thing. So norepinephrine binds to beta 1, binds to beta 2 as well. Beta 1 and beta 2 receptors are GS coupled. So that's going to, cause adenylate cyclase to make cyclic AMP. And once you get cyclic AMP from beta 1 and beta 2 stimulation, you get contraction. From here, phosphodiesterase is an enzyme that breaks down cyclic AMP back to AMP. It kind of like stops this process from happening. So if you give a phosphodiesterase inhibitor, we're not stopping the breakdown of cyclic AMP. So we're not allowing this to happen. So then cyclic AMP just causes contractions over and over again. Like it doesn't stop, which would be something good in someone that has like a shock. You don't want cyclic AMP. You don't want to stop this process. So that's why you would like put a patient on like a phosphodiesterase inhibitor. Okay, and it would be the same thing for a PDE5 inhibitor. This is milrinone was just the example that Klabunde gave for a PDE3 inhibitor. Okay, cool. So now tying everything we just did into heart failure. So something to understand about RAAS. There are really good memes for RAAS because RAAS has good intentions. RAAS is like, it's trying its best. It's like, okay, you're bleeding out. I'm going to save the day and you're going to be fine. Unfortunately, it actually makes heart failure a lot worse. Just from understanding what's going on with heart failure, RAAS is like, oh my God, I'm going to save you and you're going to be great. And then it ends up making everything worse. So it's really important to understand that, because we just talked about how great RAAS is and it's a physiologic thing that happens. It's the body's trying to like save everything, especially when we talk about pharm. A lot of the pharm for heart failure is trying to stop RAAS. It's like, all right, you're making this worse. We got to stop you. So just understand like RAAS is going to happen. It's going to happen. It's going to get released. It's just not, it's making everything worse. So that's why we're trying to block it with various types of pharmacologies. Okay. All right. So heart failure, I tried to put every single abbreviation you guys could ever see with heart failure. So HF is sometimes when you see heart failure, you'll see it as HF. Heart failure basically is the basic definition of heart failure is the heart cannot pump out enough blood to meet the metabolic needs of the body. AKA heart failure is basically cardiogenic shock. So it's even if it decreases how much it's pumping out by like a little bit, if you're not meeting those metabolic needs of the rest of the tissues, that the body can go into shock. And that's going to be what we just talked about with cardiogenic shock. Usually heart failure has this low cardiac output. There are times when cardiac output briefly increases with patients with heart failure. That's more of like a second year thing. That's like when they try to confuse you, like questions try to confuse you, but it's basically baroreceptors. Baroreceptors, like the blood pressure drops, so they kick in, and there's a brief period of time where cardiac output can go up. So if you see that, that's why. But overall, heart failure is low cardiac output. Like that's why it's heart failure. Heart is failing. It can't pump out blood, low cardiac output. So it can be classified as left heart failure and right heart failure. And this is where people get confused. Whenever you see heart failure questions, I want you to kind of read the vignette, and we'll go through this and decide, is this a left heart failure thing or is this a right heart failure problem? And we'll talk about what each of those mean. In addition to that, then say, okay, is this a systolic heart failure problem or is this a diastolic heart failure problem? Is it heart failure because there's systolic dysfunction or is it heart failure because there's diastolic dysfunction? Okay, so that's kind of how I want you to think about heart failure, left and right, as well as systolic and diastolic. All right, more definitions. Don't we love definition? I'm so sorry. I hate doing PowerPoints like this. Oh, wait. Okay, I will wait. I hate doing PowerPoints like this where it's just like a bunch of words on a slide, but PDE5, PDE5 inhibitors vasodilate, yes. That's what Viagra is, if anyone was wondering. PDE5 inhibitors are vasodilators. That's how Viagra works. The more you know, right? So it causes vasodilation, which helps. But specifically with, yes, exactly. So beat me to it. Yes. So specifically with something like a nitric oxide and PDE5. So I didn't go into this that much. I guess I could have. I can throw in a slide like in a future thing, but PDE5, it's not like an inhibitor. It basically works through cyclic GMP. So CGMP. CGMP basically causes nitric oxide to be released, and then nitric oxide causes vasodilation. So that's basically how like CGMP release leads to vasodilation. So in terms of speaking about like the one specific for the heart, it's just causing the same thing, but now in the coronary arteries, basically. But it's the same thing. So you're basically causing nitric oxide. So if you inhibit that, you get your vasodilation.
So basically, oh, okay. Wait, so are you inhibiting the breakdown of CGMP with
Yeah.
PDE5 inhibitors?
Yes.
Okay.
I know, sorry. When I don't have the slide, it's kind of they're like there's a lot of acronyms. I'll throw in a slide. I'm gonna make a note to throw in a slide to show specifically uh PD phosphodiesterase 5 inhibitors with the heart specifically. Yeah, good question. So you're inhibiting the kind of the same thing with the PDE3. Where's that one? It's just in a different area. So if you're inhibiting the breakdown, then you're not going to break down nitric oxide, and then you're going to have more vasodilation basically. It's kind of the same thing. These phosphodiesterases break things down, so if I'm inhibiting them, I'm leaving more of whatever it was breaking down. In PDE5, it would be cyclic GMP. CGMP isn't related to G proteins. Exactly. So CGMPs are not G proteins. So again, this slide is not the same. It's just trying to show a parallel. It's actually a very different pathway. It's again with nitric oxide. It has to do with arginine actually. It's like arginine breakdown. So again, I will put a slide, or I'll attach it at the end of this one before I send it to Maduka to send it out. Cool. Okay. Yeah, I did see that PDE5 was on your syllabus. I should have thrown in a slide. I apologize. But it does the same thing. You're inhibiting phosphodiesterase, which in effect does something. But okay. Okay. So, definitions. So, heart failure are the signs and symptoms. So specifically, if it says like this patient is diagnosed with heart failure, they have the signs and symptoms caused by either a structural or functional impairment of ventricular filling or ejection of blood. Okay, so this is the whole diastolic versus systolic kind of thing. And signs and symptoms are going to be based on if it's left-sided or right-sided. Okay, congestive heart failure. So when you see CHF, so congestive heart failure, this is like your classic heart failure. Like when someone that's older has heart failure, this is like your classic one. This is like there's a lot of congestion. There's a lot of fluid buildup. Like that's that one. So this is basically cardiogenic shock. So the heart is unable to pump out enough blood to meet the metabolic needs of the body. It's cardiogenic shock. A lot of the times people use heart failure and congestive heart failure interchangeably. It's fine, honestly, but just keep in mind, like, heart failure doesn't have to be congestive every single time. And that's why I'll wait till we get there. Okay, but I just wanted you to see those definitions because I know some people are like, oh, CHF, and like, they just say CHF for everything, and it's not always CHF. Systolic heart failure is going to be CHF, so you're going to have that cardiogenic shock. So you're going to have that decreased meeting of the needs of the tissues. And then you're also going to have a reduced stroke volume and reduced ejection fraction. So usually they say it's anything less than about 35 to 40% is when it's considered systolic heart failure. And again, systolic, it's a systolic problem. It's a problem with the physical pumping out of blood. So that's your reduced stroke volume, your reduced ejection fraction. Diastolic heart failure, same thing. You have that CHF, so the tissues are not getting met with the metabolic needs. You still have that reduced stroke volume, but you have preserved ejection fraction, and we're going to talk about why. When they say preserved ejection fraction, it's like it can still drop. It's just not going to be 35 to 40%. It's going to be like more than that. So it can still drop. If your normal ejection fraction is like 55 and now it's 45, it's like you're like, oh, it dropped. That's still technically like preserved, like it's preserved technically. It's again a definition thing. It's semantics. Yes, but good question. So heart failure in general, decreased cardiac output. You will always have a decreased cardiac output. That's like a defining feature of heart failure. And then the definition. So if you see HF, I think my friends in like on their fourth year rotations, they say they call them like HFrEF, HFpEF, which I love thinking of doctors saying HFrEF and PEF, blah, blah. But heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, these are abbreviations for systolic heart failure and diastolic heart failure. Okay. All right. So then kind of going after that, now thinking about the signs and symptoms. So is it more of like a right heart failure thing, or is it a left heart failure, like a left heart problem? So right-sided heart failure, this is CHF due to right ventricular dysfunction. So your right-sided heart failure symptoms are going to be, think venous congestion, think anything before the heart is going to basically get like backed up with blood. So this is buildup in the vena cava and the peripheral veins. So a lot of the times you see peripheral edema. This is what I was talking, well, we kind of briefly mentioned it earlier. It's because of that increased hydrostatic pressure. You're going to have basically fluid leaving the capillaries and the arteries and stuff going into the interstitial space. So that's what's causing the edema, like the pitting edema and stuff. Very common to right-sided heart failure only is your increased central venous pressure. So the pressure before the heart is your CVP, your central venous pressure. Okay. That's more like a right-sided heart failure thing. You can still see like edema in left-sided heart failure, which we'll talk about, but you have to remember the heart, it goes right to left. So if you're on the right, the only place it has to go is before it, which is the vena cava, as well as the the organs before it, such as the abdominal cavity as well as the liver. So that's why you can get hepatomegaly. The liver can get larger. You can have fluid in the abdominal cavity, which is ascites. It's because again, this blood that's here on the right side is just leaving and just going backwards, which is kind of what we talked about last time. It can also go up through the superior vena cava, and that's when you can get your JVD, your jugular venous distension. The most common cause of right-sided heart failure is left-sided heart failure, which I think is hilarious. But it's like, usually it's not a problem with the right ventricle itself. Usually the patient has left-sided heart failure that's gone on for so long that it developed into right-sided heart failure. Cor pulmonale, that's like true right-sided heart failure. It's like the right side truly has failed because usually the patient has like pulmonary hypertension or something. So the right ventricle is trying to pump super hard. It just can't. And then it eventually fails. But that's not the most common cause of right-sided heart failure. It's left-sided heart failure. So don't get gut. Don't be like, oh, cor pulmonale. Nope, it's left-sided. So left-sided heart failure is basically congestive heart failure, but now due to left ventricular dysfunction. So at this point, this is your HFrEF versus HFpEF thing. So the left ventricular pressure, it could be like the failure could be a systolic, like it's hard to, it can't pump out blood, or it can be diastolic. It's like the ventricle got super non-compliant, really stiff, and that's your diastolic left-sided heart failure, which we'll talk about. Usually left-sided heart failure symptoms, again, if we're here, so we were on the right side before, now we're on the left side, it's going to back up to where it just came from. So technically, if it goes back, it's going to go back to like the lungs are right before it, and then it's going to get into like the pulmonary artery, and then it's going to go to the right side. So it's kind of like it's just backing up into the pulmonary circulation, and then it, depending on how bad it gets, it can continue all the way back. It can. But right off the bat, left-sided heart failure is going to go to the pulmonary circulation. So right away, you're going to see an increase in your wedge pressure. So if you guys have been ordering Swan-Ganz catheters in case, that's what you're looking for. You're looking for, does this patient have left-sided heart failure? That means that the pulmonary capillary pressure should increase, the wedge pressure. You also hear rails and crackles heard on lung auscultation. This is like a classic thing they like to ask because they throw this in there to have people think it's like a pulmonary problem. Like, oh, there's crackles heard on, lung auscultation. Must be like a lung thing. This is always going to be left-sided heart failure. So if you hear rails or crackles on auscultation, always left-sided heart failure. More kind of lung symptoms like shortness of breath. I call this the positive pillow sign. The normal doctor term is orthopnea, but I just call it a positive pillow sign. You just ask the patient how many pillows they used to sleep on. And usually it's like, oh, like I need to be sitting completely straight up, like to sleep. Like I need to prop like 6 pillows under me. That's not good because when you lay down, it's like all the fluid kind of backs up into the lungs that's already there. And you just feel better when you're sitting straight up. So that is kind of like something you're going to start asking your patients, especially on your SPs. It's like, oh, like how many pillows do you sleep with at night? That's orthopnea. Don't write positive pillow sign on your soap note. Unless you can say, this Christina told me to write this. But orthopnea is the term. But you may or may not see edema. Like I said, this is more of like a right-sided problem, but I don't want you to see, so rails and crackles can't be right-sided. Exactly. Cannot be. Like if you see rails and crackles in a vignette, it is not right-sided heart failure. It can't be. Unless it's like left-sided heart failure that caused right-sided heart failure. But that is not a symptom of right-sided heart failure at all. That's, I feel like, something that people never it's kind of like right-sided heart failure. The classic is like your increase in central venous pressure, and left-sided heart failure, the classic is that increase in your wedge pressure as well as those rails and crackles. Okay. And then once you get to that, it's kind of like if it sounds like it's like a lung problem, but it's a heart failure question, it's going to be left-sided. And then this is what I was kind of like putting here. You may or may not see edema. Again, edema is way more of like a right-sided problem, but you can still have edema without increasing central venous pressure. It's just like another fact. So when you're seeing a vignette and you see like edema, most patients with heart failure have edema. Congestive heart failure, it's like edema. It's congestion in like the venous system. But just keep in mind, like, don't rule out left-sided heart failure if it sounds like left-sided heart failure, but then they have edema. You're like, oh no. A lot of the times it's just the left-sided heart failure that's now starting to slowly progress to right-sided. More so look at that CVP. That's going to tell you more so about your right-sided. And then finally, you're going to see symptoms of hypoperfusion. So everything we talked about, the cardiogenic shock, they're going to be cold, metabolic acidosis, the hematocrit levels might be weird, things like that. We're almost done with definitions, I promise. And then the fun stuff. So there's also some things, and I put these in here because of pharm. There's certain pharm you can give if a patient has chronic or acute CHF. So chronic CHF, I think of this as compensated CHF. It's like the patient has heart failure, but they're fine. Like their body compensated well, they're living their best life, like they're fine. You can give a patient, and I'm not saying you give all patients with CHF beta blockers. I'm just saying if it should arise that you need to give this patient a beta blocker in the future, feel free to do it. Versus if someone has acute decompensated CHF, so decompensated, it's exactly how it sounds. It's like the heart's like, nope, we're done here. So this is sudden deterioration of CHF or onset of severe CHF. Usually it's like an acute MI on top of someone that already has heart failure. It just makes it so bad. You can't give a patient like that a beta blocker. And we'll talk about that. But I wanted you to keep in mind, because that's another question I get when we talk about heart failure. It's like, well, why are you giving someone with heart failure a beta blocker? And we're going to talk about why you do give beta blockers to patients with heart failure. You can't give patients with acute decompensated heart failure beta blockers. And I have this all later. So if you guys are writing it down, I have it all later. But I just wanted to put out these terms out there because I know I'm going to get the question. All of this to say, the signs and symptoms of heart failure are going to change based on what type the patient has. And this is where I wanted to mention, you can already see the questions with the pressure volume loops. You can already see it. And depending on what type of heart failure they have, is it a systolic pressure? Is it a diastolic dysfunction, systolic dysfunction? But we'll talk a little bit about pressure volume loops. But here's kind of like the underlying mechanism behind each type. I know there's a lot on here. I should have had these pop up separately, but whatever. So we'll start here. So our HFrEFs. So our heart failure with reduced ejection fraction. So you can think of this as a systolic heart failure. So what happens is there's reduced contractility. This leads to systolic ventricular dysfunction, so issues pumping blood out, decreased left ventricular ejection fraction, leading to decreased cardiac output. Causes of this reduced contractility can be something like an acute MI, coronary artery disease, dilated cardiomyopathy, arrhythmias, stuff that we've already talked about. If we have heart failure with preserved ejection fraction, so this is more of your diastolic heart failure, the underlying mechanism here is decreased ventricular compliance. So something happened to the left ventricle that now it's not compliant. So you can imagine when the mitral valve opens up and blood comes in, it can't all get there because it's not going to expand. And like the ventricle itself isn't very compliant to begin with, but now it's really not compliant. So if it's not compliant, they call this diastolic ventricular dysfunction because there's now reduced ventricular filling. So if I have reduced ventricular filling, I'm basically not going to be able to fill my ventricle as much as I should. So they say you can see an increased diastolic blood pressure because now there's just, imagine like shoving water in a balloon and it's not expanding. It's just the pressure is going to just increase like crazy. That's kind of what's happening there. And then you have decreased cardiac output just because it's like the heart isn't acting normal. It can't really compensate for all that blood that's there. So not all of it leaves. Some of it backs up. Like it just kind of like, it's not normal. It's not a normal pathology. It's not a normal physiology state. So you get decreased cardiac output. Why does hypertrophic cardiomyopathy lead to diastolic heart failure? Hypertrophic cardiomyopathy. Yes, it can. It can lead to, hold on. Yes, because hypertrophic, same with aortic stenosis. Aortic stenosis, hypertrophic cardiomyopathy, so HOCM, they can lead to systolic because there is ejection obstruction. So that's the thing. Acutely, like you're going to have the murmur, you're going to have remodeling into like concentric hypertrophy, right? So you're going to have concentric hypertrophy. Over time, it's not really like it's systolic heart failure. You're going to have systolic problems at first because there is that obstruction, but over time, that remodeling, and we're going to talk about remodeling like next, you're going to have really diastolic remodeling because of now the thickness of the left ventricle became bigger, and now it's going to become more non-compliant. Does that make sense? So you're right. There is an ejection obstruction, which is causing like a systolic issue. I mean, it is like aortic stenosis. You can't get blood out, but it's not because it's like heart failure, if that makes sense. It's more so because it's like there's a legit block, but it's not really heart failure. But yes, over time, it can lead to diastolic dysfunction because of that decreased compliance of that left ventricle because it's just thicker now. And you'll see like eccentric, concentric hypertrophy can have all these like, yeah. Reduced ventricular. Yes. So why does reduced ventricular filling cause increased diastolic pressure? So imagine a balloon and imagine you have this balloon that's nice and stretchy. You stretch it out a little bit before you started blowing it up. Now you blow it up or you put water. We're going to have a water balloon and we're filling it up with water and it's stretching and it's really nice and it's doing what it should do. Now let's say you have a really, really, really thick balloon, basically really thick. It's not moving, it's not stretchy, and you try to fill it up with that same volume of water as you did with the last balloon. It's just the water is just not going to be, it's just going to have such an issue getting packed in there to the point where now you're increasing that blood pressure. Like the diastolic blood pressure is just the blood pressure after the ventricle fills. So that's your diastolic blood pressure. That is going to be so much higher than normal because there's no like moving with the water, if that makes sense, if you're thinking of this water balloon. But that's why it leads to that increased blood pressure because it's like now there's way more, because again, think about compliance. Compliance is a change in volume like like it's volume and pressure relationships. And that's why it's like you're not changing the volume that much, but you're still putting in this of the ventricle, but you're still adding that same amount of water. So the pressure is going to go up, basically. Does that make sense? Yeah. Okay. I wish I had a water balloon to kind of explain it. Yes, exactly. Loss of compliance. Stiff artery, stiff ventricle. Diastolic heart failure is a stiff ventricle. Your left ventricle is stiff. So anything that causes anything that causes a stiff ventricle can lead to this. So the question earlier, hokum technically can lead to ventricular stiffening. We're having remodeling there. Same with long-standing hypertension. So long-standing hypertension, aortic stenosis, anything that's going to like increase how like the remodeling of that left ventricle. You can also have diastolic heart failure if you have impaired relaxation, because again, it's the same idea. If you're not able to relax the ventricle, it's kind of the same idea behind compliance. So something like cardiac tamponade can also lead to diastolic heart failure. Usually with tamponade, you don't get to the point where that happens. The patient like just dies or they don't die, you know what I mean? But I think this idea here is like, if you can't relax the ventricle because like something is physically blocking the ventricle, like a sac of fluid around the heart, that can also technically lead, that's your decreased ventricular compliance. All right. Yeah, stiff. Cardiomyopathy. Depending on the type of cardiomyopathy. So like dilated cardiomyopathy is more so a systolic heart failure problem. So dilated, that's more of like your like it's just, you can't get enough force to pump blood out because now the ventricle is dilated. Versus something like a concentric hypertrophy, like long-standing hypertension that causes ventricular stiffening. Sometimes like, I don't even want to bring up, there's a lot of other pathologies that you guys don't have to know yet that can cause ventricular stiffening. Myocarditis can cause this, pericarditis can cause this. Like anything that's going to just imagine just like increase like the thickness of the ventricle can lead to diastolic heart failure. But cardiomyopathy, again, it's more so the type, because dilated is really not the same pathology as like HOCM, like hypertrophic cardiomyopathy. Okay. And then kind of moving in from here. Yes, restrictive. Thank you. That's the word I was thinking of. Restrictive. So restrictive cardiomyopathy would go over here as well. So restrictive would be over here. Your hypertrophic would be over here. Your dilated is over here. Just kind of think about like the underlying pathology and then be like, would the heart have a problem filling with this pathology, or would it have a problem pumping with this pathology? Okay. Cool. All right. So we talked about systolic heart failure, diastolic heart failure. So our HFrEF and our HFpEF. And then so now we're going to talk about like the left-sided heart failure symptoms. So in terms of if we have left-sided heart failure, it can either have a reduced ejection fraction or a preserved ejection fraction. If I have a reduced ejection fraction, so anything that's basically the underlying cause of a reduced ejection fraction for left-sided heart failure would be anything that's going to increase left ventricular afterload. So what we've talked about, hypertension, something like an outflow obstruction. This would be like your immediate kind of cause for this. And this is your pressure overloaded state versus your increased left ventricular preload, where you have more of a volume overload, and that's more of your eccentric hypertrophy. I think I reversed these. Oh no. I'm like sitting here, I'm like, wait, that's the exact opposite of what I said. I will fix these for the slides that you guys get. I reversed these. The HFpEF and the HFrEF threw me off. So if we have increased left ventricular, just look at the up here. It's correct up here. So left ventricular, if I'm increasing afterload, I'm going to preserve my ejection fraction because I undergo concentric hypertrophy, but it's at the expense of compliance. So over time, this can lead to diastolic heart failure. Versus I'm increasing preload, so I'm like overloading my left ventricle. So I'm going to get like an eccentric hypertrophy. That's kind of what happens with dilated cardiomyopathy. And then that's going to cause like your reduced ejection fraction. It can't pump out. It can't pump out blood because now it's like a thin-walled ventricle. It can't do it. Because remember, concentric hypertrophy, it's trying to go against a pressure. Eccentric hypertrophy, it's like, oh, okay, we need to increase the size of my cup so I can hold more fluid, basically. So that's like your volume overloaded states. And then your right-sided heart failure, usually this is again going to be anything that's going to be a left-sided problem that now moves over to like the right side. So for example, I have increased right ventricular afterload, increased pulmonary artery pressure. This is going to be left-sided heart failure basically. Or it could be cor pulmonale, right? It could be from pulmonary hypertension. Increased right ventricular preload. So examples are like tricuspid valve, like regurgitation, a left to right shunt, so something like a VSD, ASD, something like that. Anything that could increase preload. It's kind of the same idea. It's like the hypertrophy is because we get this remodeling of the right side now. Okay. Terminology. Okay, I'll fix this. And I'll show you guys too, like how they would ask this like in questions, like why it's important to kind of know all of this. And then I kind of wanted to show, I'm not going to go, I have a lot of extra slides in here. I'm not going into like a bunch of these right now. These are for you. I wanted you guys to see how they would ask questions about pressure volume loops because I want to talk about them in terms of heart failure. But this is your pressure volume loop. And then if we kind of go through the slides, you should know the normal pressures in the heart. Sometimes those are asked as like just quickie multiple choice questions. But remember with pressure volume loops, we're only looking at left ventricle. Like the pressure volume loop is just for the left ventricle. So when it's talking about like, oh, 130 and 10, it goes up to like 130 and like 10. And that's why when it's talking about systole and diastole, this is only the left ventricle. So it's just like a little reminder with the pressure volume loops. Don't really think about these other pressures. And then in terms of the pressure I put these slides in here again, I always think of the heart as a balloon filled with water. So I kind of put them in here. You guys can go through these, but just know what each of these steps are, know what's happening at each step, know what each step represents, okay? And then these are the classic questions that they might ask for pressure volume loops. So something like this where they give you like, okay, isovolumetric contraction, ejection, like ventricular ejection, blah, blah, blah. They'll ask like, where do you expect the aortic valve to open? You're like, oh, because you need to understand like, okay, what's happening with this? Like what's happening in this cardiac cycle? Where is the aortic valve opening? So things like that. Like number 2 is where the aortic valve would open. So where would the mitral valve open? Number 4. So this is all in there for you guys. It's just questions. I did want to talk about, so then heart sounds. I can tie in heart sounds into this. Blank to blank is diastole, like whatever. So here's like a more labeled one. They can ask about like where's end diastolic volume. I do want to point out, this is like a classic thing people forget. When they ask about volumes, it's always the x-axis. It's always down here. Volume's always down here. So when they ask about like preload, you're going to pick a point on here. You're not going to like be like, oh, here's the point and then go across like this and be like, oh, it's 10 or whatever. So just keep that in mind. Volumes on the x-axis, pressures on the y-axis. So something like preload would be an answer on the x-axis. Something like afterload would be something on the y-axis, okay? So even though like, yeah, here's your afterload right here, it's not, you don't draw a line down, you draw a line across. Preload, you draw a line down, okay? All right, just wanted to point that out. So remember, preload down, afterload across. And then the last thing I want to talk about before I go into like the ones I wanted to talk about with heart failure, end systolic pressure volume relationship. So it's called an ESPVR. Costanzo doesn't have like the end diastolic pressure volume relationship, which is like sometimes you'll see the line going like this. But I'll show it on another slide. But this end systolic pressure volume relationship, you can think of this as loss of intrinsic inotropy, which you're like, what the heck does that mean? But it's basically like this should only be if you're affecting the heart's inotropic ability itself, that is going to affect this line. Okay? So it's kind of saying like at the end of systole, what is the relationship between pressure and volume? So it's kind of talking about basically like systole, so this would be affected in systolic heart failure. And I'll show you what I mean when I go to a PV loop there. More questions, what changed, preload, what changed, afterload, blah, blah, blah. More questions, fun facts. Great. So heart failure, if I have systolic dysfunction, so I have my heart failure with reduced ejection fraction, the first thing that happens is your heart loses intrinsic inotropy. It can't pump out as much, okay? This is going to decrease the slope of your ESPVR line. So this line here, you can already see it's like the slope has gone down. So it's not as straight up, it's more a little bit like slanty. The heart can't pump, so now there's more blood left in the heart. That's going to increase your end systolic volume. So instead of being here, now it's all the way up here. And it's going to increase your end diastolic volume, which is basically your preload. But your end systolic volume it basically increases way more than your preload does. So that's going to decrease the width, and that's when you see the decrease in stroke volume. Because remember, stroke volume is the width of this, so this has gone down more than normal. Systolic volume decreases, but end diastolic volume increases. That's going to be a huge decrease in your stroke volume. Okay? Sorry, in your ejection fraction. And then again, your end diastolic pressure volume relationship, it wasn't on that other slide, but this remains absolutely normal. I think of the ED-PVR as being like the diastolic filling curve, which should be the exact opposite of compliance. Okay, so I'll show you that example obviously next when we talk about a non-compliant left ventricle, but I wanted you guys to see kind of like, again, all the things they can kind of ask using like one of these pressure volume loops in terms of the systolic heart failure versus diastolic heart failure. Diastolic heart failure obviously looks a lot different from systolic. The first thing to note is that your end systolic pressure volume relationship is normal. That doesn't change at all. But the end diastolic pressure volume relationship, you have an increased slope, which I guess, yeah, it's a little harder to see. But again, like I said, if it increases, this is going to be the exact opposite of compliance. So decreased compliance would lead to an increase in your ED-PVR. Okay. So then I'm going to have less ventricular filling, so my preload's going to go down. Your stroke volume simply decreases because there's less blood in the left ventricle. But since preload also decreases, so we almost have like a little, they're both kind of decreasing, or they're like decreasing a little bit, not so much. That's why your ejection fraction is preserved. Because remember, ejection fraction takes into consideration stroke volume and end diastolic volume. So this is kind of what I wrote here, like depending on those relative changes, that's why your ejection fraction might not change at all. But like I said earlier, it can still decrease. And that's going to be like even though it says it's preserved ejection fraction, it can still be like lower than normal. It's just not like really low, like in the 30s. And then your SPVR is normal. Because again, there's not a problem with systole here. And then here's kind of like a summary of both of them together, so you can kind of see the changes. So systolic dysfunction, it kind of looks like it's shifting to the right because again, you're increasing volume, you're increasing the amount of blood that's in the heart. Diastolic dysfunction, non-compliant, it's a very stiff left ventricle, so you're going to have decreased compliance. Yes, so ED-PVR and ES-PVR are the go-tos. They don't always give it to you, which is kind of annoying, but you can kind of figure it out. Like you can kind of see, like, for example, with the diastolic dysfunction ones, like it looks like it would be the same if they drew it, which these guys would not be the same, like normal versus systolic, but the EDV, oh my God, EDV, I forget already. But that's the same. It's even drawn on the same line here, the yellow. So the systolic dysfunction curve is even drawn on the normal I forget already. Let me look. ED-PVR. Okay. Whereas the diastolic dysfunction curve is drawn on a slightly increased ED-VPR. All right. So how do you diagnose it? So you look at physical exam. Like I said, not always with heart failure, because I didn't put systolic and diastolic. I just said heart failure. So plus or minus symptoms of fluid overload. Congestive heart failure, usually there's going to be symptoms regardless if it's right-sided or left-sided. You have to look more so at like, CVP and like things like that. You can also, like on physical exam, when you're doing your auscultations, they might talk about like S3 and S4 gallops. You can hear them in both. One is like rapid ventricular filling. One is like, it doesn't matter. If you see S3, S4 gallops, these are usually going to be like your heart failure sounds. Usually they'll just be like mentioned in a vignette. You do an echo. Echo, you can literally calculate all this stuff, stroke volume, ejection fraction, all that stuff. You can do an EKG. Sometimes you'll get lucky and pick up on like axis deviations, or you can even see left ventricular hypertrophy. You can also do a chest x-ray. Sometimes, again, you'll see like hypertrophy on the chest x-ray and be like, oh, yeah, all right. But the go-to is usually, this is like your diagnostic for heart failure, BNP, so brain natriuretic peptide. Don't ask me why it's called brain. Well, I'll tell you, it's also in the brain. But BNP gets released from the ventricles. So it's this peptide that gets released from the ventricles, technically is a hormone, and it's going to be released when the ventricles are stretched more than they should. So this is really important because in heart failure, the ventricles stretch more than they should. There's more fluid in the heart than they should, or there's more pressure in the heart than there should be. Okay, so as soon as that stretch increases on the heart within that ventricle, BNP gets released. And BNP is a natriuretic peptide. So natriuretic, Na, think of salt, uretic, diuresis. So this basically, you're trying to increase salt diuresis. Okay. Okay. There's also something called ANP, atrial atrial natriuretic peptide, and AMP is released by the atria. It's usually not used for heart failure. Sometimes you'll see it in like questions, but it's basically like BNP. Yes, both good questions. So BNP should still be increased any type of heart failure. Okay, so with diastolic, it's a little, so it makes sense with systolic, right? You're like, okay, like I have increased preload in the heart, I'm gonna have BNP released. Remember with diastolic, since I have decreased ventricular compliance, the pressure is gonna go up in the ventricle. This is what we were talking about on this slide, which I need to basically change. Oh my God, how many pressure volume loop slides it have? This slide. So remember, having like that stiffness is going to reduce that ventricular filling, but it's going to increase that diastolic blood pressure. So when it's increasing that blood pressure, it's increasing the pressure within that ventricle, BNP gets released. Okay, so that's why it's like a super good marker to use for heart failure in general, because it's like non-specific. It's like, oh yeah, something's going on in the heart for sure. Like this patient has some sort of heart failure going on. And then lastly, other things to look for in vignettes. Sometimes they'll talk about patients doing sputum cultures. Again, a lot of the time, remember I said left-sided heart failure symptoms are very similar to like pulmonary symptoms. So sometimes in a workup, they'll do in systolic because of increased ESP. Oh, so back here, so systolic, you'd get it because you have increased left ventricular, you basically have increased preload in systolic. So now it's like there's just more volume in the ventricle, so that even a little bit of stretch that's increasing that volume, that's going to cause the ventricles to release BNP. All good questions. Yeah, anything that's why I put, like, I didn't put specifics, it's just stretched more than they should be stretched. And then just other things again. So again, sometimes they'll give you like a sputum workup and you're like, why are they doing like a pulmonary workup for this patient? Because a lot of the times left-sided heart failure sounds like it could be a pulmonary issue. You have shortness of breath, you have crackles, crackles is always heart failure. But again, it can just objectively seem like it can be something with the lungs. So they might do a sputum culture. And when they do a sputum culture, what you'll see is what's known as hemosiderin-laden macrophages. And hemosiderin-laden macrophages, without going into what macrophages are, again, you have immuno for that, but this is basically AKA heart failure cells. Like these are heart failure cells. That is where they get, that is the name of the colloquial name for hemosiderin-laden macrophages. So if you look on this slide here, they would do like a sputum culture, they would like stain it, and then you would see like this clump of like brown red cells. Macrophages shouldn't look like this. They should look like this. Like they should look like purple. These aren't macrophages, but this is what everything in this slide should be like pink and purple. It's an H&E stain. So all of these little pockets, these are all hemosiderin-laden macrophages. These are your classic heart failure cells. So why are they in the sputum culture? So when you have left-sided heart failure, you have pulmonary venous congestion, right? You get back up into the pulmonary system. This can lead, because again, remember in pulm, well, you should have covered in pulm, the pulmonary system is a very delicate system. It's very, very low pressure. It's just very delicate. So if you have all this, just imagine all this blood rushing back into it's like, oh my God, what's going on? So that can actually like cause intra-alveolar bleeding. Like it can, just that pressure from the blood rushing back can cause the alveoli to start bleeding. And if you actually see here's an alveoli here. This is a blood, just like blood in the alveoli. So what happens is these macrophages that live in the lungs, they're called alveolar macrophages, they phagocytose, which I realize now no one's had immuno, but phagocytose just means like eat, like it just eats up. That's what macrophages do. And they just eat up this blood, the red blood cells, and then hemosiderin is a breakdown product of hemoglobin. So when they eat up these red blood cells, they break down hemoglobin, and then they look like they basically stain with hemosiderin, which is like this, it's an iron-containing compound. It looks brownish, reddish when you do like a stain. I just wanted to let you guys know what these were. Don't worry about like macrophages. Don't worry about, I just want you to, if you see this hemosiderin-laden macrophages, they're talking about heart failure cells. Like this is just classic heart failure. Okay. Okay. Finally, where it all comes together. So heart failure, pathophys, and pharm. So this is what I call the fun part because it's like everything comes together. So heart failure, regardless of what type you have, the kidneys basically think that you're bleeding out on the side of the road. So they thought you got in a car accident, you're bleeding out, they're freaking out, and they're like, we need to compensate and we need to activate RAAS. And when they do this, it actually makes the symptoms of heart failure even worse. So when we talk about heart failure pharm, all the pharm given is either going to help the heart pump better, so something like a positive inotropic agent, digoxin, which we'll talk about, stop RAAS, which is what I mentioned earlier, just stop RAAS in general. So a good example of this is like an ACE inhibitor. Stop the process of negative cardiac remodeling. So remember I was talking about cardiac remodeling. It's not good. You don't want the heart to remodel if it doesn't have to. So you would give something that would stop this process, which they can sound a little counterintuitive, but we'll go into it. So like a beta blocker, you would give a beta blocker, and you're like, why would I give a beta blocker to someone in heart failure? We'll talk about it. Or you can give something that will just make the patient feel better. So something like a diuretic, that'll make the patient feel better. It's going to treat the symptoms of heart failure. Okay, so these are kind of like the classes I want you to think about in terms of like pharm for heart failure. So usually if you look up like heart failure pathophys, you see crazy arrows and just all sorts, you're just like, what the heck is happening? So to kind of make this a little bit more digestible, wanted to walk you guys through it. So the first thing that happens in heart failure, there's decreased cardiac output, right? Like that always happens with heart failure. Even this is more of like a systolic heart failure presentation. Like this slide is going to be more for that, but overall heart failure, decreased cardiac output, it's going to be the same thing. So we have this inotropic insufficiency. That's going to lead to reduced cardiac output. The body's going to compensate with RAAS because, again, it thinks you're bleeding out on the side of the road. It thinks you're going into cardiogenic shock. It's like, oh my God, I got to increase the blood volume. So it's going to cause angiotensinogen to be converted to angiotensin 1 via renin, and then angiotensin 1 to angiotensin 2 via ACE. And all the enzymes are going to be highlighted in green. So throughout this whole slide, all the enzymes are going to be green. Angiotensin 2 gets released. And then the other thing that happens with when you activate the RAAS system is you get sympathetic stimulation. And then also angiotensin 2 is going to release aldosterone. So here's renin, angiotensin, aldosterone, renin, angiotensin, aldosterone. So that's kind of like the RAAS system that gets activated when cardiac output goes down. Okay, so we're good to hear. This is everything we talked about. I mean, everything on the side we've talked about before with shock, but just kind of seeing it. So next from here, the sympathetic stimulation, this is when the body's going to be like, all right, blood pressure went down. Let's try and compensate by putting out like circulating catecholamines. That's what they call them. So circulating catecholamines is another like almost buzzword for norepinephrine and epinephrine. That's going to increase your systemic vascular resistance. It's going to increase your heart rate. It's basically, again, trying to compensate for the decrease in blood pressure. Aldosterone is going to go to the kidneys and cause increased sodium reabsorption. It does a lot of other stuff, but in terms of like this is what it does. It increases sodium reabsorption. And when you reabsorb sodium, water follows along with it, and then that's going to cause increased volume expansion. So if I have just more volume in general kind of circulating around, that's going to increase my preload. So we have increased afterload, we have increased preload. So everything that's trying to basically right now increase the blood pressure still. Angiotensin 2 does all sorts of stuff. Remember, it releases ADH. I didn't put it on here, but it goes to the pituitary gland, causes you to be really thirsty. It's going to vasoconstrict the efferent arteriole, which we will talk about, but this is going to help with sodium reabsorption, which leads to volume expansion. It also is going to cause vasoconstriction by binding to AT1 receptors. So remember, angiotensin 2 binds to AT1 receptors on the arteries. And then volume expansion, this is where RAAS kind of makes everything worse, is it actually leads to ventricular dilation, overall just worsening heart failure symptoms. It's just going to cause more fluid to be, again, the heart can't pump blood out. That's the whole point. Now you're like giving it, here's more blood, like not blood, but here's more fluid. Here, deal with this. And the heart's like, I can't. So that's when you start getting like worsening heart failure symptoms. So the heart's like, all right, I'm going to release BNP because you know what? I'm getting ventricular dilation. I understand that's a tough word. I meant more so like there's like stretch, like there's some sort of stretch on the wall of the ventricle, which is going to cause BNP to be released. BNP, like I said, brain natriuretic peptide, it goes to the kidneys and it causes sodium diuresis. So it's trying to now get rid of this extra fluid that RAAS just so kindly just brought back to the heart. And then something else to kind of point out here, BNP gets broken down by an enzyme called neprilysin, and I'm going to talk about it's just a pharm thing, like that's why I have it here. But just understand that BNP gets broken down by neprilysin to just an inactive thing. You don't have to know what it gets broken down into. So neprilysin decreases BNP. It's kind of like phosphodiesterase decreases cyclic AMP, kind of the same thing there. And then also, this increased afterload as well as your increased preload in like a really sick heart leads to this negative cardiac remodeling. This is like the worst thing that can happen. This is like when the heart starts to undergo like all sorts of different types of hypertrophies, and it eventually can become irreversible. And that's why, again, I mentioned earlier, you want to give drugs that are going to inhibit negative cardiac remodeling, even though they sound counterintuitive, but we will talk about that. Okay. So, looking at this slide with all of these things, how would we fix this with pharm? And basically, heart failure pharm is going to touch on anything in this pathway that it can like either stop RAAS compensation, help with the symptoms, help with diuresis, help with contractility if you have like a systolic problem, or stop negative remodeling. Okay, so those 4 things are basically what's you're going to give can be like a heart failure drug. So now looking at that, the first one is going to be, and again, I tried to look at your syllabus to make sure I'm covering all the ones on there that are relevant for this. But digoxin, you can also see it called digitalis. This is what's known as a cardiac glycoside. It just comes from a plant, the digitalis plant, so it's called a glycoside. You can also give other positive inotropes. Remember I mentioned dobutamine earlier. You can give norepinephrine here. It depends on, again, this is more for like your systolic heart failure where the heart is not, it's not being good at inotropy, basically. So you can give digoxin here. So this would be like a stimulating effect. It's trying to increase inotropy. But now let's try and block RAAS, because RAAS is wreaking all sorts of havoc on the heart. So you can give a direct renin inhibitor. So the name is, I don't even know how to pronounce this, aliskiren, I don't know. But a direct renin inhibitor, know that this is like the only direct renin inhibitor that you need to know, really. And then you can also give a beta blocker. So remember, or I don't know if we covered it, but the juxtaglomerular cells in the kidney, those are the cells that are releasing renin. They have beta-1 receptors on them. So beta blockers actually can block renin production by blocking the beta-1 receptors on the JGA cells. That makes sense. Everyone forgets that renin comes from the kidneys, which are stimulated by beta-1. This is actually like a commonly asked thing. They'll actually give you like renin levels in a vignette, and then you can't, and if it's like renin levels are high and it's like, is this patient on a beta blocker? You're like, no, they can't be on a beta blocker because renin's high, you know? So just wanted to mention this. This is not the effect of beta blockers that's really good for the heart, but just keep in mind that beta blockers can also decrease renin production. And all beta blockers end in LOL. So sotalol, I don't even know, atenolol, those are all beta blockers. The next class of drugs are your ACE inhibitors. So your ACE inhibitors inhibit ACE, angiotensin converting enzyme. So they block this enzyme. So basically you don't get angiotensin 2. So this is like angiotensin 2 does all sorts of stuff here. So if we don't even let it be made, it can't do stuff. So that's good. It's a win for this patient with heart failure. Okay? All ACE inhibitors end in pril. So like captopril, I can't remember, but they end in pril. Okay. Next, we're going to talk about angiotensin 2 receptor blockers, so your ARBs. These guys end in artin. So valsarin is like a really common one. These guys block angiotensin 2 receptors. So it's like you're still making angiotensin 2, but now you're just blocking where it binds. So you're blocking its receptors here, you're blocking its receptors here, you're blocking its receptors here, you're blocking its receptors here. So it's basically like you're blocking it's basically the same thing as an ACE inhibitor, because it's as if angiotensin 2 is not there. And we'll talk about why you would give like an ARB versus an ACE inhibitor. But just know that the angiotensin 2 receptor blockers, those are your ARTINs, and those block angiotensin 2's effects, basically. Okay, next you can give spironolactone or eplerenone. So these are going to be your aldosterone receptor blockers, basically. And I highlighted these and bolded these because these are the ones that you want to give to decrease mortality in your patient. It's a common question, like which drugs would I give to decrease negative cardiac remodeling, which if you decrease negative cardiac remodeling, you're you're decreasing mortality, you're increasing like the longevity of this person's life. So I bolded these, underlined those. These are usually always given to heart failure patients, always. And it's blocking aldosterone. Next, you can give an ADH receptor blocker if you want. These are your Vaptins, so they end in Vaptin. Remember that ADH, another name for it is vasopressin. So I would always remember like Vaptin with vasopressin. It's just blocking ADH. It has like a small role. They don't usually give ADH receptor blockers for heart failure, but you can, sure. So other drugs, you can get a beta blocker. So these are the true beta blockers. So I underline, and bolded these because these are going to be the ones that you want to give to stop negative cardiac remodeling, the ones that are going to block these high levels of circulating catecholamines. Okay, is cardiac remodeling just like the changes associated with heart failure? Yes, exactly. So negative cardiac remodeling is going to be like that eccentric and concentric hypertrophy. You're trying to stop that from happening because that's going to cause the patient to basically die sooner than they should. Wouldn't beta blockers also decrease heart rate, which is bad? Oh yeah. Oh yeah. This is what I was mentioning earlier. I knew I was going to get the question. Thank you for asking. It's actually a classic question because they know they're going to get people. It makes absolutely no sense why you give a beta blocker to someone in heart failure. You're like, isn't this bad? Don't they have issues with pumping? And now you're going to make them pump less. You still actually give patients beta blockers. So I actually found, I didn't put it in here. It's like a very, very board style question, but it was basically like patient had an MI and it was like, what drug do you need to give, like absolutely need to give this patient? And above all else, you give them a beta blocker, which again makes no sense. You're like, they had a heart attack and now you're giving them a beta blocker. There are stuff you can do to kind of like make sure that that's not going to make it worse. But this is what I was kind of mentioning. You can't give a beta blocker to a patient with heart failure if they're in acute decompensated heart failure. That's why I mentioned that definition like closer to the beginning. You can only really give a beta blocker to a heart failure patient if they're undergoing, like if this is their process of heart failure, but it's like it's compensated heart failure. They're not like decompensating on the table, like suddenly dying right in front of your eyes. Usually, always, yeah, chronic long term. Again, heart failure without like they're dying right in front of you type of thing. You give a beta blocker. It's a good question. It's a confusing thing. It's going to keep coming up. Would that help to decrease arrhythmias? Just guessing. It's a good guess. So beta blockers are antiarrhythmics. Very good. So when I do, and I'm going to do briefly antiarrhythmics, like very brief, like not the level of detail you need to know for second year. But yes. So exactly what you're saying. So when I do arrhythmias and talk about the antiarrhythmics, I'm going to talk about beta blockers again and their antiarrhythmic function, but that's basically why you give them. They're going to kind of decrease the chance that the heart's going to now go into like a fatal arrhythmia, but also they can help again with this process of negative remodeling. They can kind of stop that process. And if I go back really quickly right here, see this slide with the myocardial toxicity, and then it says this, it's because of this SNS, like the sympathetic nervous system activation. So this myocardial toxicity leads to this negative remodeling, this worsening left ventricular function. SNS is this step is inhibited by beta blockers. So it's kind of like you give a beta blocker when the benefit of not allowing for this negative remodeling outweighs the risk that this patient's going to acutely just decompensate if you put them on a beta blocker. Because you can couple a beta blocker with something else that can make sure that their heart keeps beating correctly. But it's a really weird concept to grasp, and I totally get it. But it's just something that they will ask you, and you just need to know you have to give a beta blocker to a patient with compensated heart failure or like someone after an MI, and because you don't want them to go into like this negative remodeling. Ever a case where you give just heart failure patient a diuretic or no, because you would activate RAAS, which would be counterintuitive? Really good question. I'm going to actually talk about that at the end. So basically, you only give diuretics to patients to help with their symptomatic relief. So you help them feel better, which we'll get to. Actually, I think it might be next on this little slide. But you give a diuretic to help. RAAS is already active, like RAAS is already there, so it doesn't matter if you're worried about activating RAAS again. You just want the patient to feel better. So it's like RAAS is increasing volume, and then the diuretic is getting rid of that volume that RAAS increased, and then it's gonna increase volume, and then you're just getting rid of it. So you're kind of, it's like this cycle. It's like, all right, fine, like you're gonna increase volume, I'm just gonna get rid of it. Like, come at me, you know. But so that's fine, but you can't only give a diuretic to a heart failure patient. You have to give them one of these other things that's going to, back on this slide, either help the heart pump better if you have a systolic dysfunction, and something that's going to blunt the deleterious effects of RAS and stop the process of negative remodeling. Can we just do that? I know, right? Can we just give like a loop diuretic and call it a day? Okay, so technically, most of these drugs inhibit remodeling. Will they ever ask us for a specific drug that inhibits remodeling? No, it's good. These are all really good questions. That's why I wanted to really get ahead to this slide. This is the fun part, right? Because this is like the ones that I bolded, underlined. Those are the ones that like you usually always give a heart failure patient because they block negative remodeling. Like they stop this process. So from this entire list here, the doctor can kind of pick and choose what it wants to do, but usually what's highlighted, like what I have like bolded, underlined, these are the ones that are always given. But again, they can kind of pick and choose what they want to give. Like on top of it, you can combine a bunch of stuff. Spironolactone is a diuretic. So like you can give spironolactone for its diuretic effect, but really you're giving it because you want to block aldosterone, which indirectly is causing negative remodeling. Cool. You guys are gonna be pharm experts. Okay, so then finishing up with all the drugs, here's diuretics, as I mentioned. Usually you give a loop diuretic. You usually don't give like a thiazide or, I don't even know, mannitol. What are the osmotics? You don't give usually anything versus loop. You usually just give loop diuretics, furosemide, always. Always, always, always. Those are the best at diuresing, and that's kind of what you're trying to do with giving a diuretic to a heart failure patient. You're trying to get rid of the volume that RAS has now increased so conveniently for you. ARBs versus ACE inhibitors, great question. I have a slide and it's kind of like a commonly asked, I have like slides for you guys. It's like commonly asked questions. It's just questions I've seen over and over again doing pharm questions. Usually, so there are specific instances where you can't give an ACE inhibitor, so you would give an ARB instead. Usually you give an ACE inhibitor if you can. That's why if you know people with heart failure, a lot of them are just on captopril or like some sort of ACE inhibitor. But if it's contraindicated in that patient for some reason, we'll talk about a few reasons why you can't give ACE inhibitors. That's when you would give like an ARB, so like an angiotensin receptor blocker. Think that's, oh yeah, and then the last one, the weird one, but this was on your syllabus. I was very surprised Janora put this on your syllabus, but a neprilysin inhibitor. So that's not how you spell that. It's fine. Neprilysin inhibitor. So remember neprilysin, our good friend neprilysin, it breaks down BNP into inactive fragments. It's kind of, again, the same thing as like a phosphodiesterase inhibitor. You don't want to break down BNP. You don't want to break down cyclic AMP. So you inhibit the enzyme that's doing it. So in this instance, the neprilysin inhibitor that you should be familiar with, it's called sacubitril. Ridiculous name. But it's a neprilysin inhibitor. It's going to block neprilysin. And the whole point of this is to just keep BNP around. You just want it to stay around because it's doing great. It's diuresing. It's doing what it should be doing. I will say there is a common, like probably the most common heart failure drug today is called Entresto. And if you look at what Entresto is, it's valsartan and sacubitril. That's it. So it's a mix of an ARB as well as a neprilysin inhibitor. And it's a really, really well-tolerated drug. So that's why cardiologists really like to prescribe Entresto. That's all it is, an ARB plus neprilysin inhibitor. I know, I just threw out a lot of names. That's why I tried to not give you just like names. I was like, oh, the ends in pril, ends in lol. I know there's a lot of drugs, but I'm glad that you guys are seeing them first year, because like the second years were losing their minds this week. Oh yeah, they're losing their minds this week memorizing all those cardiac drugs. Okay, so what else did I put here? Oh my god, nasiratide. That was also on your syllabus. I forgot about that one. This was also on your syllabus. Nasiratide, I know, so many names. It's basically recombinant BNP. So it's basically like if whoever came up with nasiratide could give you like just normal BNP, it can't. So it gives you nasiratide. It's a basically recombinant BNP. So you just give it to the patient and it acts like even more BNP, which is great. So that's nasiritide, also on your syllabus. So don't get confused with neprilysin inhibitors and nasiritide, okay? Okay, so then I have commonly asked questions and trick questions. So these are just quick things that they usually ask a lot. Beta blockers can mask the symptoms of hypoglycemia. So you're like, cool, why do I care? So if you have a patient with diabetes and they don't realize that their blood sugar. So again, someone with diabetes, and I tried to like not go into like the specifics of diabetes too much because you'll get tons of it in endo, trust me. Endo is like diabetes block. But someone with diabetes, they can't regulate their own blood sugar. They can't regulate glucose. So they really rely on the symptoms of hypoglycemia to go eat food so they don't pass out because they don't have enough blood sugar. So what are the symptoms of hypoglycemia? It's essentially the sympathetic nervous system acting up to be like, hey, go eat some food. So your heart pounds, you get sweaty, you feel like you're going to pass out. That can all be that's basically your sympathetic nervous system acting on beta 1 receptors. Give a beta blocker, diabetic person might not know that they have hypoglycemia. So it's really, really dangerous for a diabetic person to be on hypoglycemia or to be on a beta blocker. So just make sure if you do put a diabetic on a beta blocker, you have to monitor their blood sugar levels a lot, or like remind them, hey, set reminders to check your blood sugar like every 20 minutes or something like that. If you like absolutely need to put them on a beta blocker. So this is a commonly asked question, like what drug is very dangerous, can mask the symptoms of hypoglycemia? Beta blocker. So ACE inhibitors and ARBs, these are completely contraindicated in patients with bilateral renal artery stenosis. So they love this because this is cardiorenal tie-in supreme. So you cannot give, basically what this is saying is you cannot give an ACE inhibitor or an ARB to someone with bilateral renal artery stenosis. So here's my very quick drawing of your afferent arterial, your glomerulus, your efferent arterial, your PCT. Okay. Just doing this really quick, but angiotensin 2. So remember with angiotensin 2, it does cause vasoconstriction of both the afferent arterial as well as the efferent arterial, but its effects on the efferent arterial are a lot more than the afferent. So when you give angiotensin 2, you might see like, oh no, I didn't. Okay, yeah. You'll see, I just didn't draw it, I didn't have enough time, but like you might see slight vasoconstriction of the afferent, but you're going to see lots of vasoconstriction of the efferent, just lots and lots and lots. And remember from renal, if you vasoconstrict the efferent arterial a lot, you're basically causing blood to stay here longer. So it's kind of like giving it more time to kind of like undergo, like to what am I trying to say? To filter. So to go through the PCT, so by vasoconstricting the efferent arterial, you're increasing your GFR. Okay? Bilateral renal, contraindicative of what? So, but you'll see. So I'm kind of going into the background before I go into bilateral renal artery stenosis and ACE inhibitors and stuff. So just remember, angiotensin 2 vasoconstricts both, but its effects on the efferent arterial are a lot more. So vasoconstriction of the efferent arterial, you get increased GFR. Now, if I have unilateral renal artery stenosis, so my right kidney is normal, looks great. My left afferent arterial becomes stenotic. My renal artery is stenotic. So what this is going to look like is decreased renal perfusion. Good friend RAAS kicks right in. It's like, all right, here I come. And then angiotensin 2, I didn't draw it because, again, didn't have enough time, but angiotensin 2 is going to vasoconstrict the efferent arterial here, which is actually going to increase your GFR. So even though like renal blood flow goes down, you're still keeping GFR consistent because of angiotensin 2. So see, it's not always that bad. It's just not good in heart failure. But here it's good. It's like, okay, we're keeping GFR the same as it was if I didn't have a stenotic renal artery. Also, at the same time, you also get the normal kidney compensates. So remember, we talked about how that's why you only need one kidney, because one can do the work of two. It can. So if this is getting less blood, this is going to get even more blood. And it's basically like it's going to cause I went the wrong way, but the afferent arterial is over here. Sorry, I forgot. I should have flipped them around. But the afferent arterial is going to vasodilate to be able to shunt more blood from the heart to it versus to the stenotic kidney, and then that's going to also increase GFR. So basically you have these two mechanisms playing with unilateral renal artery stenosis to keep GFR consistent, which is good. But if I have bilateral renal artery stenosis, and I realize this is on the opposite side, and the afferent artery should be here, whatever. But bilateral renal artery stenosis, decreased renal perfusion, our good friend RAAS comes into play, and then we get our efferent, I don't know what this is. All right, we get our efferent vasoconstriction here, okay? That's going to increase GFR. And you're like, great, like that's what we're trying to do. We're trying to increase GFR. But if I give a ACE inhibitor or an angiotensin 2 receptor blocker, the kidney's not going to be able to, there's no normal kidney now that can compensate for the diseased kidney. So basically, angiotensin 2 with bilateral renal artery stenosis is the only thing maintaining normal GFR. There's no normal kidney. So if you block its efferent arterial effects with an ACE inhibitor or an ARB, you can go into like acute kidney failure. So that is a classic question you cannot give. Or if sometimes they'll give you a vignette and they'll describe bilateral renal artery stenosis and be like, all of a sudden, the doctor put them on a drug and all of a sudden they went to kidney failure. What drug was it? ACE inhibitor or an ARB. Okay, it makes sense. So see, it's not all that bad, but that's a commonly asked question. This is a classic trick question. So this is kind of what we were mentioning earlier. Loop diuretics, also digoxin. People always get this wrong. Digoxin, as well as loop diuretics like furosemide, these are only given for symptomatic relief of heart failure. They absolutely do nothing for mortality. That's why you don't usually just give digoxin or you don't just give furosemide to a patient with heart failure. You have to give them something that's going to stop that cardiac remodeling. But what they're going to term it as is what's going to increase long-term survival or what's going to improve mortality, something like that. What they're trying to get at is what's stopping this negative cardiac remodeling. We talked about it, beta blockers, and then spironolactone, eplerenone. So spironolactone, eplerenone, only diuretic that does improve long-term survival. Okay. So a lot of the times, again, spironolactone is not a great diuretic. It's not like a great diuretic, but a lot of people that are on spironolactone have heart failure, and that's why. Similarly, beta blockers. So again, I know this is going to be just hard to wrap your brain around. You might just have to be like, all right, I'm just going to know it until it makes more sense later. But beta blockers improve mortality rates post-MI because they block that SNS stimulation, that sympathetic nervous system stimulation, that's going to cause that negative cardiac remodeling, that concentric eccentric hypertrophy. With something like increasing afterload, like you're increasing your SVR, it's going to cause concentric hypertrophy. So if you block that process from happening, you block norepinephrine, epinephrine's effects by giving a beta blocker, you're going to prevent negative cardiac remodeling and you're going to improve long-term survival. Okay? So all patients should be put on a beta blocker after an MI. Again, you want to make sure a patient is not in decompensated heart failure first. You cannot give a beta blocker to someone who's like literally dying on the table in front of you. I've also seen questions where it's like they'll ask what improves long-term survival, and they'll have both like spironolactone or eplerenone as well as a beta blocker. When they do that, look for other things in the vignette that'll rule one of the two out. For example, like I said with renin, if they have normal or high renin levels, they probably aren't on a beta blocker because beta blockers also decrease renin. Does that make sense? So they can be tricky. It's like I said, it's a classic trick question, so they can be super tricky. Yes, exactly. So with diuretics, ultimately, you're looking to decrease preload. You're just trying to get fluid out of the heart because RAAS is actively putting more fluid into the heart. So you're basically just trying to stop the volume effects that RAAS is doing. You're being like, all right, you're going to do it, fine, whatever, but I'm just going to completely shunt it away afterwards. That's all diuretics are doing. That's where they provide symptomatic relief. So a lot of the times they'll say like, patient was put on a drug, and so a patient with left-sided heart failure, they have shortness of breath, they have crackles. All of a sudden, they are put in a drug and they're great. Like they're feeling so much better. It's probably either going to be something like a diuretic, so a loop diuretic, or it's going to be like digoxin. It's going to help the heart pump better so it gets the blood out of the heart and just moves it into the arteries. So it's more of like a symptomatic relief with diuretics. Okay, and then, so again, like I said, whenever it asks about which drug helps improve long-term survival, the answer will only ever be a beta blocker or aldosterone receptor antagonist, spironolactone, eplerenone, not the other two. What are the other two? I don't remember. I forget. But those are the only two that can be the answer for a heart failure question. Okay. And then if both are options for answers, which I don't think they'll do first year, definitely do it second year. Look also in the prompt for other things to kind of rule one of the two out because both of them could be correct. You can also give both, but if they're making you choose one, there's got to be something in the vignette that can help you pick one over the other. And then lastly, this is kind of like I was talking about when you asked about ACE inhibitors versus angiotensin receptor blockers, like why would you give one versus the other? ACE inhibitors have like this weird side effect. We're going to talk about ACE inhibitors in immuno, if you can believe it. They have like this weird side effect. There's something called bradykinin that can build up. So let me start from the beginning. So you cannot give sacubitril, so you can't give an neprilysin inhibitor and an ACE inhibitor at the same time. If the patient is on sacubitril, you want to switch them to an ACE inhibitor. You need at least 3 days in between the two. You need a washout period. That's how intense these two drugs can interact. And the reason why is because there's a pathology state that can happen called angioedema due to what's known as bradykinin can build up. So something I left, this is the same slide as before. Something I left out from before is, so I have here's BNP gets broken down by neprilysin into inactive fragments. Something I didn't put on that slide is that there's this thing called bradykinin. We'll talk about bradykinin in immuno, but just know for now, bradykinin basically causes vessels to be leaky. It causes, basically causes vessels to be leaky, and it's like a vasodilator. ACE, so angiotensin converting enzyme, for whatever reason, as well as neprilysin, for whatever reason, break down bradykinin into its inactive fragments. So even if you're on an ACE inhibitor, neprilysin can still break down bradykinin. Even if on your neprilysin inhibitor, you can still break down bradykinin with ACE. If you're on both and you block both of these, bradykinin builds up. And if bradykinin builds up, that's when you get your vessel leakiness. You get your vasodilation. It's called angioedema. It's basically just like angio, so vessel edema. The vessels get just very, very leaky and like swollen, and the patient can die. Like you can die from angioedema. So you have to be very, very careful. So that would be like a contraindication to giving an ACE inhibitor if the patient's also on like a neprilysin inhibitor. Okay, sorry, little over. So really quickly though, because these were on the syllabus. Digoxin, they love to ask about digoxin because here's receptors or pumps. They're like, wow, ions, we love ions. So they'll definitely get a question on these ion channels. But digoxin or digitalis, remember they're the same thing. Also cardiac glycoside, same thing. It blocks this NAK pump in cardiac myocytes. You absolutely have to know that it blocks the NAK pump in cardiac myocytes. By doing this, by blocking this pump, instead of bringing potassium in and sodium out, now potassium stays out here and sodium stays in here because this pump's not working. You're not getting that exchange. So it just stays here. If sodium stays here, more of it is now available for this exchanger, this pump, the sodium calcium exchanger. So the sodium calcium exchanger takes the sodium from inside the cell, pumps it out, and then takes the calcium from outside the cell and pumps it in. Okay. And now when we have more calcium inside the cell, we have more calcium that can bind to troponin C. It goes through that, that whole, that power stroke, whatever that's called, that whole process. And that's what increases your inotropy. Okay. So this is how it increases inotropy. It causes more sodium to be inside the cell available for this sodium calcium exchanger. So now more sodium can get pumped out and more calcium can get brought in, and then more calcium inside the cell, you can have stronger contractions, positive inotropy. All right. So my question for you guys, would you expect hyper or hypokalemia in digoxin toxicity? So someone takes way too much digoxin, and now would you expect hypo or hyper? Just kind of, yeah. So kind of think about it. Yeah. Cool. Awesome. Right. Guys are cardiac pharmacologist. Very, very good. Good. So it's going to inhibit this pump. So potassium staying right where it is. So it's going to stay right out here. So you're going to see hyperkalemia. So potassium's going to remain outside the cell. Classic question. They're going to say, patient was put on a drug. and they'll kind of give you, actually, I'm going to go to the next slide because this is what they'll say. So this is another weird side effect of digoxin. There's really no physio behind it. It's just a side effect that can help you with vignettes. They'll say like patient has yellow vision. There's a word for it, something with a Z, something weird. But they'll say the patient reports having like blurry yellow vision or something like that. How they'll kind of word this is like patient was started on a drug, now they have blurry yellow vision. What's an expected side effect of this drug? Hyperkalemia. It does other stuff. I have a chart that I'm going to show. Actually, I'm going to go to it now. I made some charts for you guys with all like the important stuff to kind of know. But so for example, with digoxin, so there's other things that I can talk about in terms of side effects that I can mention in a vignette. I think that they are kind of non-specific. This is, yeah, got you guys, got you. Again, no diuretics, I apologize. Diuretics are like their own beast. I just did not have time to make diuretic charts. But this is like, you need to understand digoxin has nothing to do with improving mortality. Please don't get got on the exam. You're gonna get your exam back and be like, she literally said they're gonna do this. It does not do, it's symptomatic relief only. Same with furosemide. And then sorry, I got really excited because it's an antibody in immunology. You can actually reverse digoxin toxicity. So maybe sometimes they'll tell you, again, patient has heart failure, started on a drug, yellow vision, hyperkalemia, blah, blah, blah. What can you do to reverse the toxic effects? You can actually give an antibody to digoxin, which is kind of cool. So they call it like an anti-digoxin FAB. It's just an antibody that can bind digoxin and neutralize it so it can't keep doing stuff. All right. So that's all in here. Mechanism, indications, notes, anything that I thought that they might ask. This is kind of like sacubitril, like I said here, I kind of went into like the basics of BNP a little bit with cyclic GMP. I'll put a slide. I'll like remind myself to put a slide on cyclic GMP and then I don't think I have the 2 phosphodiesterase. I think I forgot that 3 and 5 were on here. So milrinone is a phosphodiesterase 3 inhibitor. Viagra is not a 3 inhibitor. It's just also a phosphodiesterase inhibitor. I just wanted to kind of draw the connection when you learn about Viagra and repro block. Okay, but I'll put 3 and 5 and put little slides to show that. And then your RAAS inhibitors, but specifically for heart failure. So like your ACE inhibitors, what they do, your some important notes that you can just look out for in the questions. And then I think and then other stuff too is like if you can give a direct sympathomimetic, like you can give an inotropic agent to help with someone with like some sort of cardiogenic shock. Oh, I don't know why I highlighted distributive, sort of highlighted cardiogenic. But these are also things that you can give to help help the heart beat more, or to help help to increase the blood pressure, basically. Silly question. Oh my gosh, really important to make that distinction. It is not a silly question. I keep forgetting you guys are first years. I'm like, oh, they know this stuff. Meanwhile, I was a first year. I was like, what is the heart? I don't even know what the heart does. Contraindication is you cannot give an ACE inhibitor to someone with bilateral renal artery stenosis. So indications would be like, this is who would get an ACE inhibitor. Like, this would be someone with like chronic heart failure, hypertension, reduces mortality, blah, blah, blah. Like this would be an indication to give this drug. Contraindication is like if someone has bilateral renal artery stenosis, they cannot get this drug. So it's kind of like it automatically rules them out from getting this drug if there's a contraindication. Yeah, really important question. That is like the exact opposite, right? So that's like the exact opposite of an indication. Okay. We did it. There's questions here. I think I'm gonna stay on and do them, honestly, just for the recording. If you guys want to leave and then just do them on your own time. I don't care. I don't care. Like you guys can leave at any time. I don't care. But I do want to do these questions and like talk through them, especially for the recording. Because like I picked questions that they will definitely you'll see something similar to this on your exam for sure. Again, the RAAS memes are unparalleled. But first, you guys might have already done these. I don't know if it's like a thing anymore to do these. I remember first year for me, like everyone's like, you have to do the Klabunde questions. So I did put the 2 Klabunde questions that I thought were relevant. These are really quick, hopefully. And feel free to not answer them or chat me privately. Actually, if you want to chat me privately, just so you don't feel weird about answering. That's what I do with the immunoblocks. I'll have people chat me privately. I'm like, you're answering this. I'm going to give you guys, for each question, I'm going to give you guys 45 seconds? Yeah, I'm going to give you guys 45 seconds. I'll give you guys 5 more seconds with this one. Okay, so let's talk about this one. So I actually got answers for every single answer choice, which is great. So baroreceptor reflex hemorrhagic shock. So remember, hemorrhagic shock, the issue is basically that decrease in blood pressure. So everything that the baroreceptors are trying to do is to now increase blood pressure. So let's skip to this one down here. So the first thing, if I want to increase blood pressure, I don't want to increase vagal tone because vagal tone is your parasympathetic stimulation. I would want to increase sympathetic. Like I would want to increase my sympathetic stimulation. So this guy's out. This D is like your classic trick question. So angiotensin 2 does get released, but it doesn't get released from the kidneys. Really tricky. Renin gets released from the kidneys. So if this said stimulates renin release from the kidneys, this would be correct. Angiotensin 2 gets converted by ACE, which is actually in the lungs, shockingly. ACE is in the lungs. Who knew? Well, COVID knew because it binds to ACE. But anyway, and then the last one is if I'm trying to increase blood pressure, I would want to increase systemic vascular resistance. I would want to try and do anything that's going to increase my blood pressure. So the answer to this one is decreases venous compliance. It's basically going to cause venoconstriction. Make sense? Klabunde, his hard questions. Okay, so I don't really have a slide explaining this. This is just a quick one. Okay. Next, Klabunde, and then I switch to other questions. All right, this is a little longer, so I'll give you guys like 5 more seconds. All right. So I got options for both. For the answer I wanted you guys to pick and the correct answer, which is good. So this answer is C. And I wanted people to pick A. I'm glad some people did pick A. So the NAH pump stimulated by angiotensin 2, it's really not. So in terms of cardiogenic shock, because at this point, bleeding's controlled, hemorrhagic shock, it's not really hemorrhagic anymore. It's kind of like, yeah, exactly what you said. A would not make the blood pressure go down. The blood pressure does drop. The other thing about A is it says this all happens within 2 hours. RAAS does not happen that quickly. RAAS happens after like 1 to 2 days. RAAS would not help a patient in this state, or it would not make a patient in this state undergo like cardiovascular collapse, if that makes sense. This is more so that metabolic acidosis that occurs, less specifically of the, not the NA, exactly. So the NAH pump really isn't involved here. You can still see metabolic acidosis. No, you can't. All right. We won't get into that. This is strictly from that lactic acidosis that the tissues have been undergoing like this entire time, basically. And remember, I said when it undergoes metabolic acidosis, it can actually make the cardiogenic effects worse. So it's like, even though they kind of controlled the bleeding and kind of made it seem like it's a little bit better, it immediately started to follow again, and that's like a cardiovascular kind of collapse. That's usually because of that metabolic acidosis. Okay. Yes. Anaerobic metabolism, think lactic acid production, think metabolic acidosis. It's kind of the same with like diabetic ketoacidosis. That's also that's not lactic acid production, but it's keto acid production, metabolic acidosis. Okay. Okay. All right. So I gave you guys a little hint here because they're not going to say it like this. AMBOSS is very second year, and I always try to make it more first year E if I can. So, like I said, this is a fancy way of saying this patient has bilateral renal artery stenosis. I'll give you guys like 20 more seconds. Okay. So again, I had people pick the answer I wanted you guys to pick so I can point it out and you guys won't get it wrong on the exam. So this basically is saying patient started on a drug and she has bilateral renal artery stenosis. So physical, where did it say? Okay, which of the following drugs most likely the cause of this worsening renal function? So patient has bilateral renal artery stenosis, has a drug that has made it worse. Like I said, ACE inhibitors. So an ACE inhibitor is contraindicated. You cannot give to a patient with bilateral renal artery stenosis. Now, my people that picked my beta blocker over here, makes sense, right? Like it does make sense if a beta blocker would make it worse. Remember, like I said, they're gonna give you something too. Like, I mean, I know I said that with like spironolactone, eplerenone, but they're gonna give you something that kind of helps you rule out a beta blocker. Remember that beta blockers block renin production. So plasma renin activity is elevated. It can't be a beta blocker. Does that make sense? Because if it blocks beta 1, those JGA cells won't be releasing renin, and then renin levels will be decreased or just normal. Okay. But again, if you have bilateral renal artery stenosis, and then I'll just let you guys read. If you guys have bilateral renal artery stenosis, ACE inhibitors are going to make it worse because ACE is the only thing keeping the GFR maintained, basically. Okay. Okay. It's a hard one. Okay. This is what I meant, but I said those arrow questions. You're gonna have so many of these arrow questions. I'll give you guys a good wow with this question. This is a really good question. All right, how's everyone feeling? That's 2 whole minutes, which is good, which is good. This is a tough one. Okay, so I loved seeing some of your guys' thought processes when you send it to me. You're like, okay, like it's this because I think this. Yes, so this is so let's talk through it. So we got this older guy, shortness of breath. You're like, okay, cardiac, pulm, don't know what's going on. When he's trying to lie flat at night, pillow sign. Developed shortness of breath when he's walking up to the second floor. No chest pain. He's got hypertension, so he's got these. He had an MI a year and a half ago, so he's got these risk factors. Smoked a pack of cigarettes. He's got these risk factors for heart failure. Doesn't exercise. Blah 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 blah. Okay. He's got a murmur. Fine. It's probably from the heart attack. Faint crackles are heard at both lung bases. Crackles. That's our left heart failure. That is a left heart failure. This is, remember, crackles, left heart failure. My people that said the ankle edema, for sure. For sure, you can still see, and this is, if you even go back to that slide, I was trying to be very careful when I said this, left versus right heart failure. You can still see edema in left heart failure. Because again, if he's got congestive heart failure, he's congested. It doesn't matter. He's still going to have some edema places. He's still going to have some hydrostatic pressures leaking out into the from the capillaries, from the arteries into the interstitial space. So technically, yes, edema is more of a right-sided heart failure problem, but it's only 1+. It's not terrible. This wouldn't make me think automatically right-sided. Right-sided to me, central venous pressure. That's what, if I have an increase in central venous pressure, that's always only going to be a right-sided problem. Him having 1+ ankle edema, I'm like, okay, it can be either. But if you look at everything else in this prompt, he's got crackles, that's left-sided. He's got these pulmonary symptoms. He's got shortness of breath, he's got orthopnea, and he's got risk factors for left-sided heart issues. He's a smoker, he's got hypertension, he had an MI, like he's got high blood pressure. So all this stuff is kind of like, should be leading you to think of left-sided heart failure. Okay. And again, make your little note on that slide. Decide left versus right based on which one is showing the worst symptoms. Yes, like right heart failure, you really won't see right heart failure without left. If you see right without left, that's cor pulmonale. That's going to be no left-sided symptoms whatsoever. That's going to be like, you're not going to have any shortness of breath, no orthopnea, no hypertension. Like you're not going to see things like that are risk factors for left-sided heart failure. But yes, you can think about that. Left versus right based on like which symptoms, what does it sound more like? And this is kind of like what I tell people when I'm doing pathology states. It's like boards loves to do this. So I'm kind of preparing you guys for boards. They'll give you things that would be perfect for 2 answers in the question, like the answers. Like there's things in the prompt that it's like, oh, this works for this, but this also works for this. You kind of have to look at the whole vignette and be like, does this sound more like a left-sided problem or does this sound more like a right-sided problem? To me, he's got like five like for left and like only 1 for right. So I'd be like, this is a left-sided problem. He just probably has congestive heart failure. He's probably still a little bit leaky, like in general. Does that make sense? So this is left-sided heart failure. You can see edema with left-sided anyway. But yeah. Left can lead to right. Exactly. Yeah, This could also be right-sided heart failure that's starting because of his left side. I mean, he's 72 years old and he's been diagnosed for 30 years with hypertension and he was a smoker for 40 years. Like he could be now developing right-sided heart failure because of his left-sided heart failure. But when you see something like this and they ask about the hemodynamic changes, it is so important to get that correct, like what type of heart failure the patient has. And I was just kind of trying to give my little tricks for like left side will only, like if you see pulmonary symptoms, that's only ever going to be left side, always, regardless of whatever else is there. Because it could be left progressing to right, like you said. Okay, so with all that being said, this answer is D. I had my people vote B. This was what I wanted people to pick. The only thing kind of that, I mean, if you thought it was right-sided, this would kind of, that would probably be more correct. But central venous pressure, remember, it's only going to be increased with more of like your right-sided heart failure, like your true right-sided heart failure pathologies. Additionally, you're going to see an increased pulmonary wedge pressure if you have left-sided heart failure because it backs up into the lungs. And then if you have left-sided heart failure, regardless, you're going to have left ventricular end diastolic. So your preload is going to go up, basically, especially in a patient like this, who it sounds like he can't pump it out. So it's all kind of backing up into the pulmonary system. So it's like volume is there in the heart because he can't pump it out. So I would say that this is like a systolic heart failure. So a left-sided heart failure with reduced ejection fraction is like how I would say this, or like with systolic dysfunction. Is the TPR increased because ECV? What's ECV? What's ECV? So TPR gets increased. Oh, effective circulating volume. Exactly. So effective circulating volume goes down. No, it's all good. Effective circulating volume goes down. RAAS gets activated. RAAS gets activated. Angiotensin 2 causes all sorts of stuff. So that's going to increase your resistance. So I actually put D and B on this slide because, again, wanted a lot of you guys to pick B. So yes. So this is kind of like what I was trying to get at when I was explaining it earlier. It's kind of like, where did they talk about it? So this guy's got systolic dysfunction, may be limited to the left heart, in which case elevated CVP may be unchanged. So it's kind of like CVP is really going to be more, it's going to be like, they're going to sound really leaky more so with like a true right-sided heart failure problem. How do you know when answering these questions so this is a really good question. I'm going to repeat it for the recording. So how do you know answering these questions if they want you to think about the pathology or the compensation? This is something that honestly I struggled with so much, like even all the way up into like board studying dedicated. You kind of want to think about it in terms of compensation. Well, you kind of want to think about it in terms of both, which I know is kind of not great. So for example, cardiac output is going to be decreased because this is heart failure. All the compensations that are kind of going into it. So I guess you can think of it with compensations in play because the compensations here are not changing anything other than the total peripheral resistance. So you can kind of think about it in that way. It's like the body's trying to compensate and it's probably not doing so hot. Just keep in mind, the only time this really gets really tricky is like that one question, that Klabunde question. If someone has like they're in a car accident and they're undergoing shock like right now, it's like 2 hours. Remember, you don't get RAAS within 2 hours. So it's kind of like timing kind of plays a role. But usually with this, they'll say, and that's why I like really read the question and really read like the last sentence and see what they're asking. But if it says like which of the following sets is most likely like present in this patient, it's like at this time this patient has come in. So clearly he's got heart failure and it's been like obviously not within 2 hours of him having heart failure or like within a day of having heart failure. So he probably has these compensatory RAAS changes. It's a good question. It's still kind of like hit or miss. That's why like just doing a lot of questions, especially with these arrow things, really, really help because you kind of see like what they want you to pick for these. So the only time RAAS is activated quickly is when it's released via sympathetic control. Yeah, so remember that the baroreceptors activate the nucleus tractus solitarius to release norepinephrine, epinephrine, or acetylcholine, depending on what they want you to do. That is not RAAS. That is just baroreceptor reflex, like sending out sympathetic or parasympathetic, one or the other. Yes, no problem. Thank you. Yeah, whenever you guys need to leave. Thank you. So that's not technically RAAS. That is technically baroreceptor reflex, sympathetic, parasympathetic. RAAS is going to be activated. I thought beta 1 is activated in JG cells. Yes, 100%. So at that point, then it's going to go to the kidneys and it's going to have to now stimulate renin release. Remember, renin takes a little bit of time to get made. It takes about 2 days. So even though like the epinephrine, norepinephrine, it's going there as soon as it's released, it still needs to, activate transcription. Now we need RNA polymerase. We need ribosomes, all that stuff from like molecular biology. It takes a while. So it's like, even though it goes there and it's like, hey, we need renin, it still takes a few days for it to get activated, like usually like 1 to 2 days. So you're 100% right. Epinephrine, norepinephrine, it gets released, it happens really quickly, and then it kind of starts to stimulate that process. But remember, the actual process of renin getting released takes a few days, and that's why RAAS takes a few days to get activated. Okay. Timing's really important. I try to throw it in like whenever I can throw in timing. But especially, I really, really suggest doing questions like this that are like these arrows or increase, decrease, because this is like you kind of see what they want you to pick. But keep going. Okay, keep going. All right. I think I got two more. Yeah. Okay. So, oh my gosh, you guys are cardiac pharmacologists. You guys all got this. I'm so proud. Very good. See that buzzword, long-term survival. So this guy has 100% has left-sided heart failure. Yes, he's got the pitting edema, sure, but he's got crackles. Where does it also say? Um, oh, he's got hypertension. He's got just risk factors for left-sided heart failure. But this crackles as well as his hypertension should get you to think left-sided heart failure. Increased like longevity, long-term survival, eplerenone or a beta blocker. Beta blocker isn't an option here. Eplerenone. And that's kind of what is put here. It's literally, they call it a class 1 indication, like to give an aldosterone receptor antagonist or a beta blocker. Class 1 indications, it's like if you don't give it to this patient in this state, you can literally get sued as a doctor. Um, like that's, the rough definition of what it is. But like I kind of highlighted down here, you can also put the patient on a beta blocker. Like you can, because it also would help with this maximization of its medical therapy. But again, make sure this patient doesn't have acute like decompensated CHF, because that can make it worse. So it's just saying like, just kind of be careful. Okay. And then, like I put here, none of you guys went for the trick. I'm so proud. None of you guys picked furosemide or digoxin, even though he has left-sided systolic heart failure, 100%. And it even shows, like, digoxin reduces the rate of hospitalizations. We have no idea what it does for survival. It's not the answer. Same thing. It's like, furosemide is very, very good at providing symptomatic relief, but you have not improved survival. And I'm telling you, they love this question because they know that people love to pick digoxin furosemide, okay? But sometimes they might not ask, like, about long-term survival. Sometimes they'll ask which will probably provide the best, I don't know, symptomatic relief. Furosemide is always going to be, like, the best symptomatic reliever for a systolic heart failure, okay? And then if you just kind of scroll through here, there's, like, I put other, like, this is, like, the very dumbed down version, like the more summarized version of that the thing that I did. Okay. Oh wait, oh yeah. I mean, you guys can do this one on your own. It's just I want to do this one together and then call it a day. I know it's late. I'm very sorry. Okay, I think I want to talk about this one. This is a hard one. That's why I wanted to do this one, and then we can call it a day. So, all right. This guy's got left-sided heart failure, right? So he's got left-sided heart failure. So he's using 2 pillows to avoid waking up breath at night. So he's got orthopnea, history of hypertension, high blood pressure. He's got pitting edema. He's got a gallop, and he's got rails. So he's got pulmonary congestion. So it's basically asking like, okay, this guy's got heart failure. He's 70 years old, so he's probably had it for a while. So basically, it's like, what would you expect to see in a patient with left-sided heart failure? And a lot of you guys got, and I'm actually very happy you did, again, because you won't have it on the exam. But remember, and this is a little bit more difficult than you would see on your exam. But remember, when in a state like this, RAAS gets activated. RAAS gets activated, angiotensin 2 gets released. Angiotensin 2 gets released, we're going to get increase in your TPR, you're going to get aldosterone release, which is going to cause sodium reabsorption. You're actually going to get, but this answer is A. And to my D people, elastins. So if you wanted to pick decrease in left ventricular compliance for diastolic heart failure, if you wanted to pick that, elastins and compliance are the opposite. So if you're saying, oh, he's got decreased compliance, this is basically saying he's got increased compliance by saying that there's decreased elastins. So here's my don't get got. But this is constriction of your efferent renal arterioles because angiotensin 2 preferentially vasoconstricts the efferent renal arterioles. And I know this is a lot of words on this slide, but I like reading like the little doctor thing here. So classic signs and symptoms of CHF. So dyspnea, other stuff we've talked about, basilar rails, pulmonary edema, left-sided heart failure, pitting edema, right-sided heart failure. So CHF is characterized by reduced cardiac output, which activates numerous compensatory neurohumoral mechanisms. Consider compensation too. Yes, and this is, so good thought. So increase in urinary bicarbonate excretion. So with that, that's what they're trying to get at with that, is more so talking about a metabolic acidosis. So he's basically saying like you wouldn't have like increased bicarbonate excretion because aldosterone is already going to get released at this point. And when you have aldosterone release, you actually get a metabolic alkalosis with aldosterone. So that's a good point. Like thinking B, because of the heart failure, it's more so, the heart failure is more so causing a metabolic acidosis, not because of bicarbonate, because of that lactic acidosis. But this one, they're trying to get at like the effects of aldosterone, which is actually going to decrease bicarbonate excretion. This is a really hard question. Like I'm telling you, this is a very, very hard question. It's very tricky. But always, again, kind of just trying to walk you guys through this process. You can see left-sided heart failure, right-sided heart failure. They say it kind of here at the top. If you see one, you'll usually sometimes see the other or the beginnings of the other. And RAAS is usually always activated if this is something more long-standing, not something like, again, a trauma incident on the side of the road. Okay, so then you can always think about, you should always be thinking about compensation when you answer these questions. Okay? Wow, just too much cardio for one day. So previous question, answer B. Oh, sorry. Did I already exit out? Did you mean this one? Oh, so this is basically it's like digoxin. What do you see? Increased. So you see hyper. Yeah. So we'll go through this really quickly. Sorry, I should have just gone through it for the recording. But basically it's saying patient is on a drug. Here's yellowing of her vision, digoxin. And then it goes into some other side effects you can see with digoxin. So what else would you probably see? You'll probably also see hyperkalemia. But I will send that to you guys for the future. I'm gonna stop recording.